So we are live now, sir. I'm just sharing the screen. Very good evening from Arthro TV. Welcome to Arthro TV online education webinars. Today we have IOA PG course shoulder part 2. Now I request Dr. Rajgopal sir to start the webinar. Sir, please. Sir, please unmute yourself.
Sir, unmute, sir, unmute. I have unmuted you, but. Rajagopalan sir, please unmute yourself.
Okay.
Yeah, done, sir.
All right.
Yeah, sir, please go ahead.
1 minute. Slide show. Good evening.
Good evening.
It's my pleasure to invite all of you, all the postgraduates, all those who have logged in and consultants who are logged in, all the faculty, the panelists from West Bengal and Goa, and all my colleagues for our module 6 of the Indian Orthopedic Association postgraduate teaching program, what we call e-platform. Last week we had the shoulder part 1. Today is the part 2 or part B. I am Rajagopalan. I am chairman of the IOA PG training committee. I'll be the webinar moderator for today. I basically work in Pondicherry Institute of Medical Sciences. So we had started this with the problem of not able to conduct the normal traditional one, and we had a hip, spine, knee, and now shoulder. So it's my privilege here to introduce to the audience, the faculty and our eminent panelists and office bearers of our association for this program. At the beginning, it's a great pleasure for me to welcome. He will be joining us soon. Dr. R.C. Meena, President, Indian Orthopedic Association.
Rajgopalan sir.
Sorry.
Sir, please share your PPT.
Okay. Sorry. Sorry. Teething trouble. Okay. Has it come, Ravi?
No, sir, not yet. Do it again, sir. Unshare first and do it again.
Yeah.
Not yet, sir.
Yeah, I'm just sharing it. 1 second. Usual. Now? No.
Not yet, sir.
Ravi, you can share from your side and he can speak.
I'm just trying. 1 second.
You just
maybe
open
your
presentation.
Now? No.
Not yet, sir.
Now
Yeah,
it's coming, sir. It's come.
Fine. So, start all over again.
Yeah, sir. Yes, sir.
Good evening, all of you. It's my pleasure to invite all of you for this shoulder module, part 2 of the Indian Orthopedic Association PG teaching platform. And I am Dr. Rajagopalan. I'm the chairman of the IOA PG training committee, and I'll be the moderator for this session. I am basically working in Pondicherry Institute of Medical Sciences. So we had initially hip module, then spine, then we had foot and ankle, shoulder, and last week we had the shoulder part 1. Now it's my privilege to welcome our president, Dr. R.C. Meena. He'll be joining us soon, I presume. I think all of you will be knowing there's probably no need to me to say, but he is the president of our association and professor and head of department of SMS Medical College, Jaipur. He has attended many national and made many national and international presentations, and also has got many international and national publications. He has also delivered orations at various podiums in the national and international arena, He has also chaired sessions in many of our national and international conferences. He has been guest for various national conferences and is the founder of the Pink City Orthopedic Society. He has also conducted various national conferences, including IOCON and many PG teaching programs. It's my pleasure to invite Dr. P. Shivshankar, President-elect Indian Orthopedic Association. He also, you always comes, he should be joining soon. There's also some other program for him today. He is the President-elect of Indian Orthopedic Association. He has done his graduation from Hubli, Karnataka. Then he did his post-graduation from Solapur. He has also worked in Mumbai, Birmingham, Stuttgart, and he is now has his own hospital at Solapur called IOA Orthopedic Center. He is very well known for his keen interest in the field of trauma and nailing. He has got many innovations in the field. He is a very popular trainer for all the people in the trauma. Some of his innovations include the technique of locking and also Solapur sleeve, which makes it easier, and removal of the broken nails. He has conducted over 700 workshops, twice in Pondicherry itself, and he was instrumental in the formation of NAILS in 2000, which was our first meet. The first official meet was in Pondicherry, organized by me. He was also the president. He had written many chapters in many books and journals related to interlocking. He is also a very active Rotarian. Also, he is a very enthusiastic mountain climber. He has been to many, I don't know whether he has climbed Mount Everest, but he has gone pretty near it. Dr. Ramesh Sen is the Vice President of Indian Orthopedic Association. I welcome you, Dr. Ramesh Sen. He has served more than 20 years in PGA, which all of us know, and he has been 32 years in orthopedic practice. He has authored more than 200 research papers and 10 chapters in books. He has been faculty for more than 100 international conferences where he has delivered lectures and many national and regional conferences, including in Pondicherry also. He was a visiting professor in Germany, USA, and Canada. He has conducted many live surgical demonstrations and bone molds and workshops. He has 3 patents to his name. He has done many orations, many fellowship awards. He was founder president of the Pelvic Surgery Association. He is also the past president of Northern Orthopedic Association. Lalit Mani is here. It's my pleasure to welcome you, Dr. Lalit Mani. He is very well known. His contribution to our journal is something which is worth mentioning many times again. He is the editor of IJO. He is the president-elect of Delhi Orthopedic Association. He is the director professor at Maulana Azhar Medical College, Delhi. He is also the executive editor of JCOT. He has authored several books and chapters. He has many numerous international publications, national publications. He has chaired many sessions in state and national conferences. He has delivered numerous lectures in state, national, and international area, including our small city in Pondicherry, where he came and delivered an oration which was really appreciated by all our people. Dr. Sandeep is the Joint Secretary of Indian Orthopedic Association. He is a professor and unit head in the Department of Orthopedics at Hamdard Institute of Medical Science and Research, New Delhi. He has authored several books and chapters. He was awarded the Rula Best Lecturer Award last year. He has many national and international publications to create. Welcome, Dr. Sandeep. Sanjay Dhawan is the Joint Secretary of Indian Orthopedic Association. He is the President elections of Uttar Pradesh Orthopedic Association. He is also the Vice President Central Zone IOA, was the Vice President IOA in 2018-19. He is the Director of Orthopedic Kashmir Medicare and Research Center. He is AO faculty and instructor. Besides, he has been faculty in several national and state level and conferences. I come into the members of our PG training committee who work along with me, and we all the credit goes to them in whatever we could do in the association. Dr. Harshit Shah is from Karnataka, works in MS Ramaya Medical College, Bangalore. He is a member of our committee. He is a past president of Assami, India. He is also president of our Bangalore Orthopedic Association last year. He is, of course, he is very well known for his keen interest in Elizaro and reconstruction service. He is also a very active Rotarian, and he got the Lifetime Achievement Award from our Karnataka Orthopedic Association. Dr. M.M. Ray from Calcutta is there. Welcome, Dr. M.M. Ray, and he is the member of our committee. He works in Peerless Hospital, Calcutta. In the past, he was the head of Department of Orthopedics at Calcutta Medical College. He was also the past president of West Bengal Orthopedic Association. He is also an NEC member of Indian Orthopedic Association. Welcome, Dr. M.M. Rajesh Goyal, I didn't see him. I'm sure he'll join in. He's also part of our team. He's a senior professor and HOD in Department of Orthopedics Kota, Medical College Kota. He's also a present president of Rajasthan Orthopedic Surgeon Association. He was the past president of Central Zone of IOA. He is the former chairman of IOA Basic Science and Research Committee. He has many publications and presentations. Dr. Manish, he was the person who was excellently doing this job. Just to give him some rest, I have been posted here and finding it quite troublesome. He still does all the work. I'm only reading whatever he has done. He's also the treasurer of Indian Orthopedic Association. He's the president of ASAMI. Did a wonderful conference in Delhi in March, just before the COVID stopped all the conferences. He's a professor at Yangaram Institute of Postgraduate Medical Research, where he conducted the teaching programs. So once had the pleasure to be associated with it. He's a senior consultant in Yangaram Hospital. He's also interested in the deformity correction and ILZO type of fixation. He has delivered many humorous guest lectures, and there has been constant activity in various webinars by him. I conducted many workshops and has several national interest publications. Welcome, Manish. Ravi, the young, handsome, smart man doing all the tough job for us. He is the co-coordinator, but he is the real heart of our this thing. He is in the concept and design of each webinar. He's got basic interest in trauma and pediatric orthopedic surgeon. He was faculty for our programs earlier. He works in Gangaram. He's also EC member of ASAN. Ashok Sham, I think he has the toughest job of coordinating with us. With their help only, we are able to do all this. He is the editor of Ortho TV. He works in Pune in the Sajjad Institute. He is the chief researcher and head of the IORG. He is also editor of JOCR. He is a basic research committee member. He is an ex-member of MOA, UAA, BYS, and Pune Orthopedic Society. Dr. Andrej Bijlani is also the coordinator for the Ortho TV. He is a consultant orthopedic surgeon and at Ortho Clinic, Mumbai. The Samsul Hoda is the coordinator of Ortho TV, coordinator and the consultant orthopedic surgeon Patna. He is joint secretary of the Orthopedic Association, Assam, India, and DOC. He is also editor of Ortho. Now, coming to our faculty, I will come to each one of them. Dr. P.P. Kotwal, known to all of you, he was the ex-professor at HOD of Orthopedics. He was also the chairman of the same PG committee previously. He is also now the chairman of Institute of Orthopedics and Joint Replacement in Pushpavati Singhania Research Institute, New Delhi. His correct CV would have gone to miles. Somehow I at least could put something into this one slide. He is a visiting professor of the in Nepal. He is also a member of Board of Studies of various universities. He is the founder chairman of Hand Section. He was the president of Indian Society for Surgery of the Hand from 2015 to 17. He is a former chairman AO, authored many books and numerous chapters, given many oration, guest lectures, and publications. Welcome, Dr. P.P. Kotwal. Dr. Gopinath, he said he will join us at about 7 o'clock. He is from Calicut. He was previously in Calicut Medical College, where he started the famous Calicut PG teaching program, one of the maximum crowd drawing one. After that, he left. He developed the spine surgery there. After that, he joined another ICRA Industrial Hospital, where also he conducts PG teaching program. He is also the chief editor of Journal of Orthopedics. He has many publications and presentations. He also chaired various sessions in the state and national conferences and also international. Welcome, Dr. Gopinath. Dr. Gopakumar, my friend, I have made this biota very easy for me because I at least saved some time on that. Dr. Gopakumar was professor of head of department of Calicut. Now he's professor of orthopedics in MES Perindalmanna Medical College. His basic interest in pediatric orthopedics and is an excellent teacher. Dr. Sandeep, he works in Mumbai. He's a honorary professor. He's a president-elect of Bombay Orthopedic Society. He's a consultant orthopedic surgeon in Saifi, Jaslok Bhatti Hospital, Mumbai. His, of course, specialization is known to everybody. It's a complex trauma, non-union joint replacement, lumbar spine. He has presented, I've had many occasions to be listening to his excellent talks before, many conferences. He has presented many papers in national, international, and or many other conferences, conducted many workshops. He has 18 publications. Welcome, Dr. Sandeep. Dr. Sibin Surendran, young, handsome, smart man here. I know him from even from the student days, I think, postgraduate student days. It's so pleasure to and happy to see him here as faculty. He is additional professor at Government Medical College, Calicut, Kerala. He is basically interested in adult reconstruction and arthroscopy. Dr. Surendra, hearty welcome from all of us from the IOA PG Teaching Program Committee. The Bhupesh Karthik is a person, he works in Hosur, but you can never find him in Hosur. Tough to get him anywhere for that matter. Busy, traveling here, there, comes to Pondicherry. Twice he has come and delivered orations, talks for us in our state conferences and also in our YSSCon. He's a consultant arthroscopy sports medicine person in Trivandrum, and also he's a visiting person in Ramachandra. In fact, the last I think I met him was last 2 years back. I met him for the orthobiologics in Ramachandra. He is the Joint Secretary of Tamil Arthroscopic Society, very popular faculty in the arthroscopy field. He is Executive Committee Council member of Indian Arthroscopy. Welcome, Dr. Bhupesh. And our panelists for today are from West Bengal and Goa. Dr. Chinmay, he is the president of West Bengal Orthopedic Association. He is a professor of orthopedics. He is a recipient of the Shuddha Award by IOA. He has been a postgraduate examiner, paper setter, and thesis adjudicator for different states. He has numerous publications, international, national, and state levels. Written 2 books on Atlas of Orthopedic Surgery, Orthopedic X-ray, and Prevalent Orthopedic Diseases. It's our privilege to have you here, Dr. Chinmay. Thank you for coming. We welcome you. Dr. Patsardi Sakhar is the Honorary Secretary of West Bengal Orthopedic Association. He did his undergraduate MBBS from Arjikar Medical Calcutta and MS Ortho from NRS Medical Calcutta. And he's associate professor in NRS Medical College. He has done a study on operative introduction lower cervical spine injury, has several publications, and he is interested in spine. Dr. Patsardi, it's our pleasure. I welcome you as our panelist for today. Dr. Zelio is from Goa. He is the president of the Goa chapter of India Orthopedic Association. He is associate professor and HOD of the Goa Medical College, and he has pioneered joint replacement surgery in Goa. His special interest is in replacement of the joints and scapular surgeries. He has conducted numerous workshops. Dr. Zelio, it's our pleasure. We would have happily had it in Goa and welcomed you, but unfortunately we are not able to do that. So it's my pleasure to welcome you here. I hope I get a chance to welcome you in Goa. That will be still more nice. Thanks for joining. Sure. Thank you, sir, and thanks for joining. And welcome. And last but not the least, Dr. Mahendra, Head of Department of Orthopedics, Hetway Hospital, Group Hospital, Goa. He is the best medical graduate of the year 1989. He is a national faculty of foot and ankle surgery. So we have a really very different specialty trained people here. He is a national ATLS instructor. He is a national AO faculty. His special interests are in adult reconstruction and joint replacement surgery and foot and ankle surgery. He is the president-elect of Indian Foot and Ankle Society. Congratulations, Dr. Mahendra, and it's really happy to have you here. Whatever I said for Ducilio holds good for you also. Definitely, I like to see you and meet you in Goa. But for the time being, we welcome you to this program. Please, thanks for coming. Thank you all. And with that, I close. I have taken adequate time. Back to you, Ravi. Thank you all.
You can call the first speaker, sir.
Yeah, let me. So we'll start the program today. First talk will be by basics of shoulder arthroplasty by Dr. P.P. Kotwal. Dr. Kotwal, please.
Sure. Good evening, everybody. I'm grateful to Professor Rajgopalan and Manish for giving me an opportunity to be a part of this webinar, basically on the Teachers' Day. I think that's really a great coincidence for that matter. Sorry, just. Yeah, is it visible? Am I?
Yes, sir. Yes, sir.
Yes,
It's
yes.
working, sir. You can
Visible and audible.
I'm going to speak on basics of shoulder arthroplasty. And the shoulder actually enjoys the greatest range of motion. It has an inherent bony instability, and the stability depends upon the soft tissues. And you can see this, there is very little glenoid bone stock, and therefore it's not like a stable joint of the hip, the acetabulum and the femur. So the shoulder arthroplasty, the incidence wise comes third after the hip and the knees. And a little bit of recapitulation about the anatomy. The scapula is 30-degree anteverted to the coronal plane. However, the glenoid is retroverted by about 4 to 15 degrees. And the humeral article surface is also retroverted. So this is actually in contrast to the hip, where when we put the joint, we put it into little anteversion for that matter. And there is the relative posterior humeral offset. We will talk about some important landmarks. Bicipital groove. This is the bicipital groove where you have the tendon of the long end of the biceps. It's an important landmark because it helps you in judging the height of the prosthesis, particularly in the setting of a trauma where all that is broken in the humerus. Then when you put a prosthesis, you have to measure by the tension in the long head of the biceps. And also when you put the prosthesis, the fin of the prosthesis, it is kept about 10 to 12 millimeter posterior to the bicipital groove. So that gives the correct retroversion in humerus, which is about 30 to 40 degrees. The shoulder arthroplasty has mainly can be divided into 3 types. One is the hemi-arthroplasty. The second is the shoulder arthroplasty, and the third is the reverse total shoulder arthroplasty. The main indications for arthroplasty of the shoulder would be pain, severe loss of function, and end-stage arthritis, which can be because of osteoarthritis, rheumatoid arthritis, avascular necrosis, post-traumatic arthritis. However, trauma has now also become an important indication for the shoulder arthroplasty, particularly proximal comminuted proximal humerus fractures in the elderly with osteoporotic bones. These are the various prosthesis types which are available, which are either for replacement or for total replacement for that matter. Let's talk about the hemi-arthroplasty, and this is the commonest indication, is used commonly in the trauma, and also otherwise people have used with good results in glenohumeral arthritis, but now it has become less common. The hemi-arthroplasty has become less common with the advent of glenoid resurfacing or replacement, which gives better results. So in trauma, what are the indications? 4-part fractures and fracture dislocations, like you see in the picture here. The head of the humerus is lying into the axilla. The head splitting fractures, which cannot be reconstructed. 3-part fractures, particularly in the old osteoporotic patients, and malunions and non-unions of the proximal humerus fractures. So these are the indications where you would do a replacement. So here is an example. This is a fracture dislocation of the humerus. You can see it so well. And then this is also the head splitting. That's the head of the humerus, where actually this cannot be reconstructed. And therefore, this is an indication for doing a hemi replacement of the shoulder. And some of the tricks would be the prosthesis size should be identical to the original head, like for any other prosthesis for that matter. And the important thing is, as I told you, about the height of the prosthesis, because as I told you, in the proximal humerus, the head is removed, and all the greater tuberosity and the lesser tuberosity, they're all broken into pieces, and therefore it is very important to be able to put the prosthesis in the correct height and the correct length. And so this actually can also be judged by, after putting the trial one, if you are able to put the lesser tuberosities, if they are not too comminuted, maybe that also gives an idea that you are the height of this thing is correct. But otherwise, as I told you earlier, the tension of the biceps tendon, and that must be preserved, that in your dissection, that gives you an idea about the tension of the soft tissues and the correct positioning of the prosthesis. And obviously, as I told you earlier, this has to be put into certain degrees of retroversion. Another important point is tuberosity repair. This is important whether you are doing an internal fixation by a plate or screws, or even for doing an arthroplasty. So it requires a stable fixation for an optimal results. One has to use heavy non-absorbable sutures. Avoid using wire sutures, because they sometimes may break. And the sutures are actually important. They are passed through the bone tendon junction and not through the soft bone of the tuberosities, because they will crush it further. Maybe sometimes if there is too comminuted, one may use the bone grafts between the tuberosity and the tuberosity metaphyseal junction. However, when cementing the stem, keep the cement away from the tuberosities, because if the cement comes in between the tuberosities and the shaft, then perhaps because the fracture will not, those tuberosities will not unite with the main stem. And obviously you have to balance the appropriate soft tissues. So here is an example of a comminuted fracture and replacement done by the hemiarthroplasty, and that's the result at the end of 1 year. Let's talk about the total shoulder arthroplasty. This actually, other than the humeral component, this has the glenoid component, which is actually a polyethylene component, and it alleviates pain and improves function. The replacement consists of both the humeral as well as the glenoid. Actually, the humerus is the convex part, like the head of the humerus, and the glenoid is the concave one. However, one important caveat is that this is done, the total shoulder arthroplasty is done only in patients with intact rotator cuff. There have been multiple studies which says that in osteoarthritis, the total shoulder has given good results, about 10 to 15 years survival, and the total shoulder arthroplasty is better than just the hemiarthroplasty. In total shoulder arthroplasty, age and general health of the patient is also very important. The younger patients, more active patients, put more strain on the shoulder joint arthroplasty, and therefore there are more chances of glenoid loosening and wear. Whereas the young RA patient, rheumatoid arthritis patients, they benefit better because they have polyarticular disease. The tissues are not very strong, not very normal, and that actually limits their activity. So the joint replacement lasts longer in rheumatoid arthritis. The active older patients have the best results after total shoulder arthroplasty. And these are the two, this thing we just now talked about. This is the hemiarthroplasty, just the replacement here, we saw that. And this is the total shoulder arthroplasty with the glenoid replacement also performed. The total shoulder arthroplasty is indicated, I said that, I'm repeating it, is when the rotator cuff is intact. And so what if the rotator cuff is not functional? So let's recapitulate the anatomy. The rotator cuff muscles consist of four, the muscles, the suprascapularis, the subscapularis, the supraspinatus, infraspinatus, and teres minor. All of them, they work together to stabilize the humeral head in the glenoid fossa during shoulder motion. So this is what the rotator cuff does. See, normal shoulder, the deltoid forces are acting upwards, whereas the rotator cuff muscles, they have a force downwards. So what happens is when the deltoid is abducting the arm, the rotator cuff will keep it lower down against the glenoid. So that will allow the full rotation and abduction of the shoulder. So this is the function of the rotator cuff. So what happens if there is a massive rotator cuff tear? There would be superior migration of the head of the humerus that you can see here. This is now migrated upwards. It is touching the acromion, and there occurs what they describe as acetabularization of the coracoacromial arch. So this becomes like an acetabulum, and whereas this becomes like the femoral head. So now it becomes a this kind of joint. So what will happen if a total shoulder arthroplasty is done in a cuff deficiency? This will rise up, and there will be rocking horse phenomena, which will cause loosening of the glenoid component. So therefore, in those situations, the reverse total shoulder arthroplasty is the solution for that. And here it is just the reverse. That's why it is called as reverse. That means the humeral component is concave and the glenoid component is convex. And this was designed in 1985 by a French orthopedic surgeon. So what is the basic concept, design concept of the reverse shoulder? The basic concept is shifting of the center of the joint rotation medially, which increases the lever arm of the muscle. And this is how it does. In normal situations, what you have is the center of rotation is in the convex portion of the head of the humerus. And whereas in reverse total shoulder, what will happen is that because now the convex surface comes onto the glenoid, so the arc of rotation is also in the center of this glenoid, and this causes medialization of the center and lowering of the humerus. Therefore, it increases the lever arm and increases the strength in the deltoid, because the reverse shoulder uses the deltoid to achieve active rotation. So it is not dependent on the rotator cuff for that matter. And so this is how it is. Helps. It happens rather. So this is the L is the lever arm, and this increases by medialization and lowering, and which increases the force in the deltoid. That acts exponentially. The indications for reverse shoulder would be the glenohumeral joint arthritis associated with irreparable rotator cuff tear, absent rotator cuff, complex humeral fractures, and revision of failed total shoulder arthroplasty, and in elderly patients. Contraindication would be obviously where the deltoid is deficient. Just to quickly run through the steps, the V chair position, deltopectoral approach, and you would take the cuts in the humerus. And once the humerus cut is taken, then you approach the glenoid and work on the glenoid, and then you put it a metal base plate, and then you fix the head, the convex head onto the glenoid side, composed component on the glenoid side. And this is the humeral canal, and you are putting in the humeral component with a concavity plastic at this end. And this is how the articulated joint will look in the operation theater. This is an example in a fresh fracture, comminuted fracture of the proximal humerus. And this is after the reverse shoulder surgery done. And there are articles which prove the better or the efficacy of reverse shoulder in fracture situations, 2013, 2014. And this is another patient who had a non-union and a rotator cuff deficient shoulder, reverse shoulder arthroplasty done. And that's the range of movements, the external rotation, the internal rotation, and so on. This can also be used for failed fixation. You can see here, this is now eroding the glenoid articular surface. The CT scan shows the same thing. And this is corrected by reverse shoulder arthroplasty. And that's his result, functionally reasonably good result. And this is the multiple surgical scars. Another patient of the division from an osteosynthesis, rotator cuff orthopathy and secondary osteoarthritis, reverse shoulder done. And that's the range of movement. The operated side is on the left side. And this is another one for osteoarthritis. That's the result. This is another 85-year young person with reverse shoulder, and that's his range of movement. A very important slide. This patient, same patient, he had the two procedures done. This is the standard hemiarthroplasty, and that's the reverse shoulder. And you can see the functional result after each surgery. This is another patient, 88-year-old female. He has severe osteoarthritis of the shoulder. And for some earlier fractures, she had this plate in place. So we had to do the reverse shoulder. So we just removed the earlier proximal screws so that the reverse shoulder could be done. And this is the functional range of movement at the end of about 6 months. The reverse shoulder is also actually can be done to convert conventional shoulder arthroplasty to reverse shoulder arthroplasty. The complications are the notching, infection, loosening, and also breakage of the implants and implant failure. This has actually come out from the bone. I will end up with with this particular case. There was a 72-year-old male who had injury to his left shoulder about 8 months back and inability to move the arm. There was diffuse tenderness. The only positive finding was the muscle atrophy and global restriction of the movement. This is for my postgraduate students. This is his X-ray. And I would like to draw your attention to look at this. There is an overlap between in the shoulder here, that's the glenoid outline, and that's the humerus. So if you see an overlap, otherwise it looks normal, you should be suspicious. This is most likely the posterior dislocation of the shoulder. And you can see here, this is the glenoid, the head of the humerus has gone back, and this is the very big Hill-Sachs lesion. And this was since 8 months old in an elderly patient. And there is also a lot of arthritis of the glenohumeral joint. The CT scan also shows the head of the humerus lying posteriorly. And this obviously, the MRI shows the same thing with deficiency in the rotator cuff as well. So the diagnosis was neglected posterior dislocation, glenohumeral arthritis, and rotator cuff deficient. So obviously the choice of treatment would be reverse total shoulder arthroplasty. And this was the post-operative X-ray. This was his range of movement at the end of 6 weeks, and this was at the end of 6 months, and that's his range of motion. The operated side is the left side. So to conclude, the hemiarthroplasty is indicated mainly for trauma these days. The total shoulder arthroplasty is indicated for osteoarthritis, rheumatoid arthritis, particularly in the middle-aged, not very elderly persons, in inflammatory as well as osteoarthritis. And the reverse shoulder is gaining more popularity now, particularly with the aging population and particularly for trauma, osteoarthritis, rotator cuff arthropathy, generally above the age of 69 or 70 years of age. Thank you very much for your attention.
Thank you, Dr. Kotwal, for an excellent talk and covering almost everything needed by the postgraduates. Now, the questions will come from the postgraduates later, the other people who are listening, audience. Now, what we will keep is that if there is anything more the faculty want to convey to the postgraduates, I think that can be asked. Can be told to the postgraduates, or if any particular clarification with Dr. Prakash Kotwal, that also can be done. Then I will come to the panelists from the other schools. So any of the faculty want to either add anything or want to make some clarifications? Harshad, welcome, Harshad.
Yeah. Sorry, I was late. My duty
problem.
today. Welcome, everybody. Thank you for coming, Dr. Kotwal gave an excellent brief lecture. Wonderful it was, very, very clear. What I would like to know is, if the rotator cuff is still present and you can repair it, can you do a reverse, or do you want to do only a regular total shoulder arthroplasty?
Well, good question. If it is generally an elderly person, 69, or and they say, in that range, 65 to 70 years of age, and if the rotator cuff is torn or if it is deficient, then it is generally, as you know, very difficult to repair that, to be able to have a very active function of abduction and rotation after the surgery. So therefore, generally, the consensus today is that without bothering about the rotator cuff, if the deltoid is good, if it is very good in function, then it is better to do a reverse shoulder arthroplasty rather than doing total shoulder. Because in total shoulder, if the rotator cuff is not working well, then perhaps the result will not be very good.
Thank you, Dr. Prakash. Dr. Ray, anything you want to add? Anything you want to clarify?
I just wanted to know from Dr. Kotwal, apart from trauma and arthritis, what about the malignancy or the neoplastic lesions in tumorous conditions? In what are the indications in particularly in neoplastic conditions? What are the chances or the incidence of total shoulder arthroplasty?
Yeah. Actually, if the tumor is involving the proximal humerus, generally, that's when the replacement indication would come. And in that situation, generally, if the proximal humerus is gone, that means the tuberosities and everything, they would actually also be removed. And therefore, again, after using custom-made prosthesis, depending upon the resection of the humerus, then there can also be an indication for doing a reverse arthroplasty. Otherwise, if it is in the younger patients, generally if the tumor is in younger patients, then it is preferred to do a total shoulder arthroplasty, not go to a, and that's why actually in my slide also said that generally it is indicated for trauma in elderly, but in the younger patient, it must be used with caution. You must actually see the rotator cuff and the other possibilities, and if possible, it is better to do a total shoulder arthroplasty than doing a reverse shoulder.
Thank you, Dr.
Actually-
Kotwal. Dr.
Actually, what is the minimum muscles required for arthroplasty? That means either deltoid or rotator cuff. Minimum. What should?
For reverse shoulder, you require a very good deltoid. That's the only requirement. So that's why it becomes easier that you concentrate only on the deltoid and remove the other muscles as well.
Thank you, Dr. Kotwal. Dr. Rajesh Goyal is, I think, is not here. Now I come to faculty. Dr. Sangeet, anything you would like to add more?
Dr. Kotwal has said very clearly, like the reverse shoulder is a last surgery. There is no surgery beyond that, and you cannot do a revision. That is one thing. Second is the reverse shoulder is built on the bone stock of the glenoid. If the bone stock of the glenoid is not good, don't consider reverse shoulder. And for the benefit of students, like one of the faculty has asked, what is a requirement of a intact muscle for a reverse shoulder? There is a similar question which will be of interest to them is what is a requirement for a total shoulder? What are the minimum muscles required for a total shoulder arthroplasty?
For the total shoulder, you have to have a good rotator cuff.
Okay.
Intact. Then only this total shoulder.
And see, the decision is based clinically. So how will they check whether the rotator cuff is intact and how strong is it to consider the decision between a total shoulder and a reverse shoulder?
In that situation, an MRI can certainly help you. The MRI will give an indication or give you an information, I should say, that what is the status of the rotator cuff, which actually we all do every day in our practice for shoulder.
Thank you, Dr. Kotwal. Dr. Gopakumar, anything you want to add?
No. Nothing, sir. I think Kotwal sir has told everything that is necessary for the students. I don't have any further to add.
Thank you, Gopakumar. Dr. Bhupesh?
I have a question.
Yeah.
Yeah, thank you. First of all, thank you, IOA PG team, for inviting me, and the IOA President sir and Secretary sir for inviting me in this PG course. Now, I have little to add that, Kotwal sir, can there is anything to counsel the patient before doing this surgery, because this is the now the complex trauma is increasing, so the scope of this hemiarthroplasty or the reverse or the total arthroscopy plasty is increasing. So what is the main thing that have to counsel before going for this arthroplasty procedure? Is there anything special to add?
Not really, because you are replacing the joint. So obviously the joint has this joint will have a limited life. The long-term studies have said about 10 to 15 years survival after the joint replacement, even for shoulder or reverse shoulder for that matter. That's number one. And the second thing would be that actually it all depends upon a very good therapy program. Most of the patients actually would not follow that or not able to follow that. So the result may not be really very good, although it is a mid-arm or a mid-resting range movement possible most of the times. So if their therapy program is good for at least for 3 months after surgery, then they can expect a reasonably good function from that shoulder. So this is actually I would like to stress upon and counsel the patient about that.
So does that mean if you have to conclude a patient who cannot participate in a good physiotherapy program or a rehab program, he is not an indication for a replacement surgery?
Yeah, see, the surgery has to be done. If he has a proximal humerus fracture and where the reverse shoulder is indicated, obviously surgery is required. Otherwise, there is no way you can do an osteosynthesis. So that treatment left out for him. But obviously, I would like to emphasize upon him that, he must follow that. Whether he follows that or not, it's a different issue. But about the counseling and telling patient what to do, so that importance, I would like to definitely give it to the patient.
Kotwal sir, only Kotwal sir, in failed cases or in dislocation cases or in infective, where you will have to remove it, in almost like lending to flail shoulder. In what are the other possibilities to do or how to solve the problem?
Well, for the
cases.
For the benefit of students, if there is a old dislocation or where it is not possible to give a mobile joint or after a joint replacement, then for a shoulder a good option otherwise is an orthodesis. Even for infection also, if the infection is controlled energetically with the help of debridement and antibiotics and everything, as a second stage, one can do an orthodesis of the shoulder, which also generally works reasonably good for such situation.
Reasonably, okay. That to some extent, some movement will be there. Some scapulothoracic movement
movement will give rise to some degree of rotation for that matter.
Thank you, sir. Actually, I'm just going in order so that we don't miss out anybody. I will finish the faculty, then I come to our office bearers, then come to panelists, so then maybe reverse it in the next round.
Okay, that's good. Sorry, we are
No, sir, so that I don't miss out anybody. That's my
that should be.
And I will reverse the order so that doesn't go in the same order. And I got Dr. Bhupesh and Dr. Sibin here, the other faculty had to join. Dr. Bhupesh, anything you'd like to tell us? You are an arthroscopy man, I know.
It is a fantastic lecture by Professor Kotwal. I thoroughly enjoyed it, sir. Thank you for teaching us on Teachers' Day. I have nothing more to add to it, sir. Fantastic.
Thank you. Dr. Sibin, anything more to add?
Yes, Dr. Kotwal, sir, that was really covered everything. So I just want to highlight one thing. The reverse shoulder arthroplasty is the treatment for rotator cuff arthropathy. It's not a treatment for an unrepairable rotator cuff. Many of the students in an old age for an unrepairable rotator cuff without arthritic changes, say a rotator cuff tear, they are more than 60, 65 years. So it's a treatment, end stage treatment, as Dr. Sandeep Gawal has told. It's an end stage treatment with a lot of complications can happen if you are not technically good. So it's an end stage treatment, and it's not a treatment for irreparable rotator cuff tear. It's a treatment for rotator cuff arthropathy when the joint is completely arthritic, and it's the last treatment that no other option should be available for the patient. Otherwise, that was everything well covered, sir.
Thank you.
Thank you, Sibin. The point is taken. Is Dr. Lalit Meni there? Dr. Lalit? Dr. Lalit?
Yeah, I'm there. Thank you, Dr. Kotwal, for an excellent talk. One basic question in a postgraduate exam, should we start expecting students to identify the implants of a reverse shoulder?
I think that would be too much.
Won't be kept.
If the discussion comes about, they must know some basics about.
Basics. Okay.
Yeah, that's what actually I did not go into the detail, because that I thought would be a level of higher than the postgraduate examination level.
Thank you.
Thank you, Dr. Lalit. Now I'll come to the faculty. Can I ask Dr. Chinmay, Dr. Sir, anything you would like to add, ask, or clarify, whatever you want to say? Dr. Chinmay Dey?
Yeah.
Yeah. Can you hear me?
Yes, please, yes.
Yes, sir, we can hear you.
Yeah.
This three-part fracture or four-part fracture where the separation is unmanageable. Should we straight away go for the replacement, or should we at a first step reconstruct? What is the guideline?
Actually, his voice was breaking. Can somebody help me with?
Yeah, even I am not able to hear Ravi.
Can somebody help?
I repeat. I repeat.
Yeah.
Three parts or four parts fragment where it apparently seems to be unmanageable. That is a very complex fracture. So, as a first step, should we first reconstruct the fracture, and then as a second step, as in well case, we should go for replacement, or straight away we should go for replacement? What is your guideline?
I'm sorry, I just
reconstruction or replacement?
Dr. Chinmay, your audio is pretty bad. Even I'm not able to make out anything. He said, anybody else can hear his this thing?
Maybe
Manish?
he can type. Maybe he can type his question.
Maybe somebody. Manish, would you be able to hear?
You can type the question to the group.
I actually is logged out with a mobile phone.
Okay.
I suggest him that please, sir, log in with a laptop, sir. Dr. Chinmay, please log in with a laptop.
So I'm with the laptop.
Because the laptop. Okay, so you just remove your headphones once and again put it back. Or you exit and again log in. So I think that will improve your audio.
Sir, I think what Dr. Chinmay is asking is,
or you can write and show me like that.
in a bad 4-part fracture of the shoulder,
yes.
When as a surgeon, when you go in, would you first like to reconstruct the tuberosities, however bad they are, and try to salvage it with osteosynthesis? Or would you directly decide that you are going to do an arthroplasty and go ahead?
Yeah,
Is that right, Dr. Chinmay? I think that is the
right.
Day-to-day
Yeah,
challenge.
right. This is the question.
Thank you, Bhupesh. Yes, sir.
Yeah, this is the challenge. Actually, these days, with the help of CT scan, that gives you quite a good idea about the fracture configuration, in the sense that whether it is head splitting, what are the sizes, and even if the head of the humerus, how big is the piece of the head of the humerus, whether if you are reconstructing it, osteosynthesis, whether your screws will actually hold, have a hold into the head of the humerus or not. That is, having said that, but still, if you go by, as like to go by the deltopectoral approach, if you go by that, you can still try to, it has happened 1 or 2 times earlier also, that if you go by that, we try to reconstruct the head of the proximal humerus, I should say. And when we could make out that it's not possible to do that, then we converted this thing and converted into a replacement. Obviously, you have to keep that ready on the table as well. But generally, as I said, nowadays a CT scan and a proper study of the CT scan can maybe help you beforehand.
Thank you, Dr. Kotwal. Dr. Patsardi, anything more you want to ask?
I have already asked you some questions. So
Thank you. Dr. Zelio, anything?
I would like to know 2 things. Can you hear me?
Yes, sir. Yes, sir.
Yeah. Regarding the version, when you're doing a hemiarthroplasty, do you have any other landmark besides your fin, which you said, to judge the version in a hemiarthroplasty? And the second question is, what is your post-op rehabilitation protocol following a hemiarthroplasty?
Yeah. One is actually, as I said, is that fin.
Yeah.
Tendon of the biceps, which actually helps you quite considerably for that matter. Number 2, it will also to certain extent, you can judge by the tension in the soft tissues to certain extent. This is the only other thing.
Can you use the interepicondylar axis of the elbow when you keep the thing at the side of the shoulder?
That actually helps. That actually, you can do that when you have that jig. The jig also tells you that you have to keep it in line with the forearm. So that gives you to that, but that will give you about the retroversion.
Yeah. I'm talking about version only, retroversion.
2 components. One is the retroversion. The other is the height of the process. That the long head of the biceps and the tissue tension in the tissues. And the rotation is by the transcondylar axis that you are saying. And the post-operative protocol would be that you start with the pendulum exercises on day 2 or 3 as the pain permits and the patient's motivation of that. You will start with the pendulum exercises day 2 and 3. By the end of first week, you will go with the gentle passive exercises, then active assisted exercises. So generally by the end of 2 months, 8 weeks or so, you should be having a reasonably good range of functional movement. Of course, the patient's motivation and this thing is important, but you would start after 2 days, at least.
Thank you, Dr. Kotwal. And Dr. Zilo, Dr. Mahendra is here. I don't see him. Is he here?
No, he will log in later on, sir.
Okay.
He is busy.
Okay, I think that we have almost taken 1 hour for the first lecture and the questions. We are very happy to have the questions, but be prepared to have a late dinner. So unless we become okay. Dr. Bhupesh, can you give your talk, share your screen for basics of arthroscopy?
In the meantime, Dr. Rajgopal.
Yes, sir.
Yeah, you've been a nice chairman. If you'll allow me one more question to Dr. Kotwal.
Short question. Only what was
short one. You are talking about arthrodesis. What is the functional position and the best position of arthrodesis of shoulder joint, please?
Relevant question. Okay.
Yeah, fair enough. It's a shoulder examination for
yes,
postgraduates.
students may be asked.
Good question.
Yes.
And students can quote Dr. Kotwal if he says that in the Bible. Yes, sir.
Yes.
Well, actually, the incidence and this thing has gone down of doing orthodesis these days with the availability of the joint replacement. But generally, I would the optimal position of orthodesis for the shoulder is about 30 degree of abduction and about 30 to 40 degree of external rotation. So the arm should be in line with the forearm should be in line with the arm, and he should be able to reach to the mouth.
But Harshad, you will not ask the students all this, okay? I don't want them to fail. Okay.
No, the counterpart of hip questions come automatically into the shoulder joint.
Dr. Bhupesh, please. Before Harshad asks another question, please stop.
No problem. No problem. Nice, very nice lecture.
Very nice. Very nice. Well, thank you, sir. Thank you, Dr.
It was covered up very
excellent.
Well. Thank you.
Okay. Sir, is my screen visible?
Yes, it's visible.
At the outset, I would like to thank Professor Rajagopalan for inviting me into this prestigious meeting. Thank you, Team IOA. Fantastic job. And this talk will be on basics of shoulder arthroscopy. It's a very big topic. I will try to cover what is important for postgraduates and, if possible, also try and inspire them to take up this exciting field. So, in shoulder arthroscopy, when a surgeon starts from being a knee arthroscopy surgeon and progresses to be a shoulder arthroscopy surgeon, he has to look into positions of the equipments, position of the patient, and of course the portal position. The equipment position is something new with arthroscopy because we have a lot of gadgets and we should know how to optimally place them in the table, in the OR, so that we don't have trouble later on. Ergonomics is the study between man and machine and their interface. Now, if the interface between the surgeon and the arthroscopy set is good, and if you can manage them well, everything will fall in place. The typical arthroscopy tower will consist of the monitor, camera, light source, a radio frequency device shaver, and the pump. The most important thing is to keep a good high definition monitor. It is around 10 to 15 degrees lower than the surgeon's eye level. If it is lower than the surgeon's eye level, then the next strain for the surgeon will not be there and he will be able to operate at ease. The distance between the surgeon and the monitor should be at least 5 times the diagonal of the monitor so that his vision is adequate and he can see a larger picture of what is happening. Too close or too far away will again be trouble. The elbow of the surgeon should be at 90 degrees to the target site. There are new tables which will go down so that he can instrument the shoulder joint with ease. This will avoid abduction of the shoulder surgeon and thereby leading to rotator cuff injuries to the shoulder, to the surgeon himself. If the surgeon, the target area and the monitor are in a coaxial line, he will not need to turn around each time to look into the monitor and back into the shoulder, and thereby again prevent fatigue during the working hours. I will come back to this later. So placement of the arthroscopy and the patient adequately correctly in the OR will improve the performance, will prevent fatigue, will reduce surgical time, and thereby will definitely prevent complications. For a new shoulder arthroscopy surgeon, the new kid on the block is the pump. Can the host mute audio, please? I'm not able to hear. Dr. Shamshul, can you mute the audio disturbance? Yeah, thank you. So the pump is the new equipment that comes into the operating room, and it has to be kept higher than the patient and not as the last instrument, last equipment in your arthroscopy trolley, because if it is kept down, you have to keep pumping it so much more to get adequate amount of hemostasis and visualization during arthroscopy. So this instrument should always be kept in a separate rack higher than the patient's heart or the shoulder so that it works adequately. Now, shoulder arthroscopy is commonly done in two positions, in the beach chair and lateral. It is usually the surgeon's preference and the way he's been trained. The advantages of beach chair position is that it is easy to convert to an open procedure if it is difficult to complete it arthroscopically. There is mobility of the upper limb. You can internal and external rotate the limb as you're doing the surgery, but you need a special head holder for this. And cerebral hypoperfusion is a dreaded complication which is feared by the surgeon and the anesthetist with beach chair position. The advantages of lateral position is that it is very familiar. We have been doing our hips in the same position. Hence, the shoulder position is easier for the technicians. In the OR, limb is put on traction. No other special equipment is required other than a traction tower, and there is no anesthesia related risk in this position. There is no single position which is better than the other. It is all the surgeon's requirement and how he's been trained to do the surgery. But when the position, I'm a lateral position surgeon, and in lateral position, as nicely discussed by Professor Kotwal, since there is retroversion in the shoulder, to keep the glenoid parallel to the floor, the patient is tilted backward around 20 degrees to negate the retroversion and keep the glenoid parallel to the floor in this manner. This is a fancy pneumatic shoulder system for traction, used as a traction device to suspend the shoulder. I have the luxury of using this. I learned my shoulder arthroscopy using a manual traction device like this, which is a 3-point traction system. And because I'm a traveling surgeon, I also do many arthroscopies with the traction system being just an IV stand and suspending on it. What this appears to say is that the traction device is important, but not the most important thing, because adequate traction, very high traction is not required during shoulder arthroscopy. The limb has to be just suspended, and with good technique, you can manage with whichever equipment we have. Now, the surface marking of shoulder arthroscopy is very important. I still do it till this day. With the thumb, palpate the supraspinatus notch and make the borders of it. Anteriorly, start marking the anterior aspect of the clavicle, which will blend into the acromion through the AC joint. And there you will find the anterior edge of the acromion, which will continue to become the lateral edge of the acromion. And posteriorly, you will find the posterior angle of acromion, which will continue to run into the spine of the scapula. Anteriorly, that is where you have the AC joint. And just under the clavicle, you will also mark the most important landmark, which is the coracoid corsage. The posterior portal is the workhorse. That is the first portal that we make. It is the initial viewing portal. It is situated 2 centimeters inferior and 1 centimeter medial to the posterolateral corner of the acromion. And once you ballot the humeral head, you will find a small space between the stable glenoid and a moving humeral head, where your posterior portal will go just between your infraspinatus and the teres minor. The other way to palpate it is putting the middle finger on the coracoid, your index finger on the notch, and your thumb will palpate the soft spot between the infraspinatus and teres minor, which will take you to the posterior portal. So a lot of other posterior portals are made, but the standard posterior portal is what we just saw, which is here. And for posterior labral work, the portal is usually shifted a little more laterally. For remplissage, it is shifted a little more superiorly. And for pure subacromial access surgeries like your rotator cuff repair, it is shifted a little more towards the posterior border of the acromion, so that subacromial access is easier. The lateral portal is another important portal for arthroscopic rotator cuff repair. It gives access to subacromial space. It is situated 2 centimeters from the lateral border of the acromion along a line drawn along the posterior border of the clavicle, as shown in this picture. Never go more lateral because your axillary nerve is at around 4 to 5 centimeters below the lateral edge of your acromion. This portal is usually made by first passing a needle into the subacromial bursal space. This is the bursal space. And once the needle is seen, the portal is made with a blade and a switching stick is inserted to work on it. The anterior portals are the workhorse for instability work. Outside in technique is an old technique. We don't do that. Inside out technique is an old technique and we don't do that now. We need precision in placing our portals and to plan the trajectory of instruments through these portals. So we do the outside in technique with a spinal needle. We also prevent overcrowding by having adequate space between the two anterior portals which we use for instability, which will be the anterior superior and the anterior inferior portals, which we will see in the later slides. Both the portals are made in the safety zone, which is the rotator interval. Anatomically speaking, this is the space between the subscapularis, which is in the front, and the supraspinatus, which is above. Arthroscopically, we will see this between the biceps, which is seen here, which is just in front or intraarticularly to just in front of the leading edge of the supraspinatus, and this is your subscapularis, and this is your labral tissue. The triangle formed here is your rotator interval, and since there is no rotator cuff here, it is a safe zone for portals to come inside, and it will not disturb or tear the rotator cuff by making portals here. So these are the two portals. These are done by outside in technique. The first portal is made by introducing a needle high in the triangle, as you can see, and this is the needle which comes all the way down to the lower half of the glenoid. This trajectory is important because only then we can place anchors well. If it is too low, then the anchors will ski off. Just behind the supraspinatus, in front of the supraspinatus, behind the biceps, your anterosuperior portal will come. It is important for the needle to be able to switch on either side of the biceps like this, so that anterior and posterior viewing of the glenoid labrum will be good, and there will be no overcrowding. The angle between these two should be 30 degrees, which is called the azimuth angle, because your anterior superior will become your viewing portal, and the anterior inferior portal will become your instrument portal. And if it is in 30 degrees, the surgeon's hands will not hit each other, and working in the depth will be easy for him. The posterolateral portal is a good viewing portal for rotator cuff surgeries. That was a view from the posterior portal. Once you switch it from posterior to posterolateral portal like that, you will see the tear much better. And yeah, the Navier portal is another portal which is made in the notch 2 centimeters from the posterior border of the acromion notch. It is used to take the bites in rotator cuff surgery. The port of Wilmington is another for slap repair. There are multiple portals, and as we progress in arthroscopy in the shoulder, each another can be used. Can somebody mute the audio disturbance, please?
Ravi, can you mute everybody other than Bhupesh Karthik? There is some background disturbance. Somebody has not muted himself.
Yeah, thank you, sir. Thank you so much. So, since this is a broad topic, I will talk about the commonly addressed problems. Shoulder arthroscopy is a fantastic field, very similar to trauma. As trauma surgeons, we would want to see immediate fantastic results, and we can see the same with shoulder arthroscopy in terms of instability. A patient with recurrent shoulder dislocation, which is very, very difficult for him to manage day-to-day activities. He might have dislocations in his sleep. He might have dislocations when he's washing his hair. He might have dislocations when he's waving his hand, when he's riding his two-wheeler. So when such a difficult problem is existing, you do a simple arthroscopic stabilization, he will be happy for life. An elderly patient having a drop arm positive, not able to lift, when a good rotator cuff repair is done, the patient will have function and strength later, including strength later on, and will give back good mobility and use of the upper limb. People with stiff shoulders not getting better with conservative treatment with a good capsular release will have excellent immediate outcome. But stiff shoulder surgery shoulders are now coming down because we have fantastic conservative treatment protocols to treat it. So we very commonly addressed two problems, anterior instability and rotator cuff tears will be discussed now. This is how a diagnostic arthroscopy will look. You go in, this is the lighthouse, the biceps tendon. There will be bubble. Once that bubble is removed by letting in some water, you will see the biceps tendon, that is the rotator interval. Minimal fraying of the supraspinatus is seen in the back, and that is the rotator interval in the front. That is the subscap. Minimal fraying is seen. That is the MGHL. You don't see the anterior labrum here because this is a case of anterior instability where the labrum is missing. And that is the posterior labrum. That is the huge hill sac in the back of the humeral head. You can see a lot of bone bruise and loss of articular cartilage. And that is your axillary pouch. And that completes the diagnostic arthroscopy. Now, once the anterior portals, like we discussed before, is made in the rotator interval, you will go in and start looking from the front. So this is the same patient. This was when we were looking from the back, when there was no labral tissue at all seen from the posterior portal. Now this is viewing from the anterosuperior portal and instrumenting from the anteroinferior portal. We see this kind of picture in our country regularly, patients with 10 dislocations, 15 dislocations, or even much more. So once we go in, we don't see adequate labral tissue, but gently with a good elevator, if we work on the depth and slowly start elevating, and there you start seeing true labral tissue stuck all the way down in the neck of the glenoid. This is the neck of the glenoid. You will have to elevate till you see the muscle fibers of subscapularis. And when you do that, what looked like there was no tissue, some amount of true labrum can be salvaged and a good repair can be done by doing this. Now you can start seeing some amount of good capsulolabral tissue, which looks like can be put back into the glenoid. That is your labral bulk. Now what looked like nothing looks like a good tissue, which can be repaired back into the glenoid. Now, the two advances in arthroscopy in terms of instability is planning the location of the repair and addressing the capsulolabral laxity, capsular laxity. So Kaposi and Savoyd moved the entry of the anchors from the neck to the face of the glenoid, just along the edge of the rim of glenoid. And these are all suture anchors. We have moved away from metal suture anchors because we don't want metal in glenoid now. Because all suture anchors are easier to revise and they are very, very small, 1.4 to 1.7 based on the company. And this is called a suture passing device, a lasso or an accupass. And that is your labral tissue, which is brought in, shuttle relay is done, and this suture is put back. What we saw was an alpha lesion, which means the labrum was healed in the neck. It was elevated, brought back to the face of the glenoid and repaired using a suture anchor. Sliding knots are made like this on the capsular side so that the knots don't irritate the articular cartilage. After the first anchor, which is placed at 530 in the face of the glenoid, lower, which will form the tension in the inferior band of the IGHL or the inferior band of the inferior glenohumeral ligament. The anterior band of the inferior glenohumeral ligament, the humeral head will be stabilized and brought to the center. Second and third anchor at 4:30 and 3 o'clock are then made, and the sutures are cut later on. This will give fantastic patient incredible shoulder later on in his life. Can somebody note the audio disturbance, please?
Ravi, it is Dr. Shah's one.
Yeah.
Not muted. Dr. Memamle is not muted.
Oh, sorry.
Yeah, I'm.
Thank you, sir.
Hello.
Sir, please.
Hello.
Dr.
Yeah,
Ray,
yeah.
please.
I have muted. Just.
Yeah. Thank you, sir. Thank you, sir. So this is a overview of anterior shoulder surgery, anterior shoulder instability surgery, which is arthroscopically addressed. The second part of the problem is rotator cuff. This is above the glenohumeral joint in the subacromial space. A patient comes with drop arm sign, is having a difficulty to actively lift her arm. Then an arthroscopic rotator cuff repair will give fantastic results. Now we are working in the subacromial space. There are basically two types of arthroscopic rotator cuff repair. The single row repair, which is shown in this video, which means the shoulder is looked into, the rotator cuff is mobilized, reduced, and suture anchors are placed in the greater tuberosity, which forms the footprint of the rotator cuff. You can use bioabsorbable anchors like this after tapping it, or metallic anchors in the humeral head. These are retrograde passing devices. A needle will come in and will bite through it like a scorpion, and then the threads are moved. First two mattress stitches are made, and this stitch is taken carefully between the two mattress stitch. And this is called the SCOI technique, or the Southern California Orthopedic Institute technique. Now the second suture anchor is made, similar suture passing is done. And once the mattresses are tied, the simple suture is tied, which is in between these two mattresses. And this configuration prevents cut through, and the knots are then cut off. This forms that is shoulder movement and very stable rotator cuff. This is called single row repair. And the remnant of the footprint, you do multiple small microfractures. Good blood will come from the bone marrow here and will make what is called the crimson duvet effect and will enhance healing by biologicals. This is called the single row repair. Now commonly the double row transosseous equivalent repair is done. For example, in this video, this is a small tear. I'm viewing from the posterolateral portal. This is just a very small tear. We debride the footprint and go in and put in a bioabsorbable anchor in the greater tuberosity, which is the footprint of the supraspinatus. These are fantastic suture anchors with very good pull-out strength. And you have 4 sutures coming out through it. Take mattress bites from each of the 4 suture. The previous video, what you had seen was an older generation suture passer. This generation suture passer also helps in passing the suture and retrieving it in the same sitting. Multiple arthroscopic knots are made with a knot pusher like this. These are extensions of your fingers to come in and put knots. Once multiple knots are made by knot pusher, then these knots are collected and brought to the lateral aspect of the humerus, around 1 centimeter down from there, and the lateral aspect of the humerus is cleared, and a second suture anchor is placed here, which will take all these suture anchors from the medial row. In the single row, we cut off all the sutures in the medial row, but here you put another lateral row. These sutures will keep the footprint down and will compress the supraspinatus back into its footprint. A larger area of compression is achieved. These are biomechanically stronger, and early range of movement can be started following the surgery. So this is an overview of shoulder arthroscopy and where it is useful. The take-home messages are that shoulder arthroscopy, as a beginner, during PG days, you should have some interest. The posterior portal is the first portal that is made. Anterior portals are workhorse portals for instability work. Your lateral portals are workhorse portals for subacromial work and rotator cuff work. Anterior instability addressed arthroscopically with adequate technique gives fantastic results. Rotator cuff repair is a very good surgery, brings down the pain of the patient and also restores function. So I would request our PGs to take more interest in this. This is a fantastic evolving field. Thank you, teachers, and thank you, students, for the...
Thank you, Bhupesh. It was an excellent talk with fantastic video, very informative. Thank you. I will go back from the reverse order. So can I first ask Dr. Zelio, sir, I hope Dr. Mahendra is here. If he's here, I'll ask him. Sir, will you like to, Dr. Zelio, would you like to add any information, make any clarification, or there's any questions to the fact, Dr. Bhupesh? Sir, you have to unmute yourself, sir. Thank you.
If you have a subscapular stay, in addition to your rotator cuff tear, do you do both this at one sitting, and what is your take on?
So rotator cuff repair, we always try to talk about supraspinatus, but as we all know, subscapularis is actually a much stronger muscle than the supraspinatus. The subscapularis and the infraspinatus are very important in centering the shoulder. If there is a subscapular tear, it has to be addressed without fail, because addressing the subscapular tear will prevent anterior-superior escape, which will later on lead to rotator cuff arthropathy. So it is usually done in the same sitting without making it staged. It takes another few minutes to go and put an anchor in the lesser tuberosity from anteriorly, take bites in a very similar fashion to supraspinatus, and tie the knots, putting it back to its footprint. That's a fantastic question, sir. Thank you. It has to be repaired.
How commonly do you do subacromial decompression for impingement syndromes? How common is this in your practice?
In the 1990s, it was one of the most commonly done surgeries, as you very well know. But now we have brought down doing it because we find that with very good conservative management, we can try and avoid these. If there is a very big spur which is coming and giving a lot of trouble, and if the conservative treatment fails, very rarely we do an isolated subacromial decompression and acromioplasty. It is very rare nowadays, not as frequent as it used to be. And even with rotator cuff repair, we do very minimal acromioplasty now. And
okay, thank you. Thank you.
Dr. Bhupesh, now can I ask Dr. Parsarthi, please, sir, any questions, any comments, or any suggestions?
Yeah, thank you for your excellent presentation.
Thank you, sir.
We have a basic question, that is what is the instruction to the anesthetist for this shoulder arthroscopy, whether this hypotensive anesthesia is advocated or not, and regarding the position, this beach chair position and this lateral decubitus position, what is the advantage and disadvantage, and if there is any relationship with this hypotensive anesthesia with this position?
Yeah, I will answer one by one, sir. First, with respect to anesthesia, the cerebral hypoperfusion is a dreaded complication with beach chair position. But if your anesthetist is very good and he can give a good hypotensive anesthesia, then there is nothing to be worried. In lateral decubitus, even if multiple anesthetists come visiting you, it is still very safe because you are not worried too much about cerebral hypoperfusion. That is the advantage with lateral position. With respect to hypotensive anesthesia, we usually ask our anesthetist to keep the systolic BP less than 100. To achieve this, nowadays, instead of giving more amounts of drugs, what our anesthetists are doing is they give an interscalene block. An interscalene block along with GA, which will bring down the pain inhibition and then bleeding during the surgery. So the interscalene block also works as a fantastic post-operative analgesic. And it also brings down surgical time because bleeding during the surgery is very low, and the anesthetist is able to fantastically maintain hypotensive anesthesia without pushing in a lot of drugs. Coming to common advantages and disadvantages, again, it is very theoretical. If the surgeon is used to doing all the surgeries in beach chair, then it is wise for him to do it in the same position. If he is a person who wants to do it in lateral, it is wise for him to do it in lateral. But other than the anesthesia-related complications that we fear in beach chair, posterior labral repair will be a little difficult with beach chair because your scope is posterior, you are standing posterior, and there is very little place. But on the other hand, arthroscopic rotator cuff repair might look a little more simpler in beach chair because you're viewing everything anatomically. Lateral position, you have to train your mind to look everything on a lateral way, but in a beach chair, you're seeing everything anatomically. And if the surgeon is not able to complete the rotator cuff repair arthroscopically, he can very well make a small lateral deltoid split approach and complete the job, which might be little difficult in the lateral decubitus position. Other advantage of feature is the surgeon can do an arthroscopic latarge procedure, which cannot be done in lateral because of abduction of the arm, and mobility of arm is always a problem. You cannot internal and external rotate the arm, which is very important to do surgeries medial to the coracoid. I hope I've answered the questions.
Thank you, Bhupesh.
Thank you.
Is Dr. Chinmay there? Dr. Chinmay? Okay. When he comes back, we'll ask. Then I'll go back to the office bearers. Dr. Sandeep. Okay, Dr.
Yes,
Lalit. Sandeep, you there?
Yeah, I'm there.
Yeah.
Sandeep, you want to add anything to the talk by Dr. Bhupesh?
Yeah.
Dr. Gopinath, welcome. Sandeep, anything more you have to add?
Yes, for the students which are appearing in the exam, now the shoulder scopy is a difficult procedure for them. Now, the commonest indication are the rotator cuff tear or shoulder instability, where you're repairing the Bankart. So can both this procedure be done by an open procedure if they don't have the arthroscopy equipment? How are the results, comparable results? And what is the advantage in a given situation where they don't have equipment, where they have not undergone a training? So can they do an alternative procedure which can be open?
Thank you, sir, for the question. This is a fantastic question. This is a question that might be asked to the postgraduates on a different form, asking what are the advantages of arthroscopy and advantages of open. Open Bankart repair or open Bankart repair is gold standard. There are no two ways about it. But open Bankart repair is not easy. The surgeon should know very well to go and do a good open Bankart repair. Tissue liberalization is very important. And first I will address instability, then I will talk about rotator cuff. And placing the anchors on the face of the glenoid and not the neck of the glenoid, which might be a little easier with open, is also important. Because if you place the anchors on the neck of the glenoid in open deltopectoral, we see the neck better than the face. So if we put it there, we are recreating an ALPSA lesion, which is anterior periosteal sleeve avulsion. So you have to put it back into the neck. That was the biggest change that was done by Kaposi and Savoy, which improved the results of arthroscopic Bankart repair. But if you can put the anchors on the face, open Bankart repair is a fantastic surgery and there is no downside to it. The advantage of doing it arthroscopically is we minimize blood loss. The other lesions, such as a biceps lesion or a superior labral lesion or a hidden posterior labral lesion, can be addressed in the same time with arthroscopy. And of course, there is postoperative morbidity is low and quicker return to function is the advantage of arthroscopic Bankart repair. You can visualize other structures and treat concomitant problems by doing a diagnostic scopy in arthroscopy. Less blood loss, smaller scar, earlier return because of postoperative pain relief. But on the other hand, there is no downside to open Bankart repair. It is a fantastic surgery if the surgeon can do it well. Coming to rotator cuff repair. Open rotator cuff repair is again a fantastic surgery. The advantage of arthroscopy is better visualization of the tear pattern. Once the tear pattern is judged better and the releases of the rotator cuff is done better, reduction and putting in anchors and putting in knots can also be done by a mini open method. If the surgeon can complete it by arthroscopy, well and good. But the true advantage of arthroscopy is that you will be able to assess the tear geometry better, do adequate releases, do a biceps stenotomy at the base if required, take care of subacromial decompression if required. So these added points and better visualization and understanding of tear geometry is the advantage that we have with arthroscopy over open. But it can be done by open also.
Dr. Bhupesh, yes, I will now go to the faculty. Sankeet already asked. Dr. Sibin, anything you want to add, Dr. Sibin? The arthroscopy man.
Yeah, Bhupesh, this was like Very informative and nice talk. Very good videos. Just wanted to ask one thing. You have mentioned about the fluid pressure system. What is the ideal fluid pressure system you advise? And suppose there is no fluid pressure machine is available, what are the other options available?
Fluid pressure system as low as possible. Never keep it high, because momentarily you might have very good field, but then the shoulder will bloat up. So as we know it, as low as possible. I never cross 30, 35. My standard is 25 is my pressure. The important thing, as I mentioned, the pressure pump should be kept higher in level and not as the instrument lowest in the rack, because against gravity it has to pump that much more and will keep increasing the pressure unnecessarily. If you don't have a pump, there is nothing to worry. You have to have a good anesthetist who will give hypotensive anesthesia. Especially instability work can be very well done without a pump. Many experienced surgeons are doing rotator cuff work also without the pump. But if there is a pump, it adds to the advantage.
Thank you, Dr. Bhupesh. Dr. Gopakumar, anything you want to?
Yeah, one common case that is kept in the exam is a recurrent anterior dislocation of the shoulder, which the students usually say, and in the X-ray they find a big Hill-Sachs lesions. What will you advise to the students as the method of treatment of this? A recurrent anterior dislocation with a large Hill-Sachs lesion.
Sir, I intentionally didn't go into that because it might not basics, but Hill-Sachs has to be quantified. So we have to know whether it is an off-track Hill-Sachs or on-track Hill-Sachs, which means if is the Hill-Sachs engaging in a very common term. And these are done by various CT measurements. We identify the width of the glenoid and we try to see the width of the Hill-Sachs. And we can see, we have to try and understand if after the repair of anterior labrum, the Hill-Sachs should not engage. And if the Hill-Sachs engages after the repair of the glenoid labrum, it is going to be a disaster because it is a sure shot for failure. In those cases, to address the humeral defect, we do a procedure called remplissage, which literally means filling in. Coined by an American surgeon who was trained in France. We put in anchors posteriorly into the humeral head and tenodase the posterior capsule and the infraspinatus into the defect, and thereby prevent this Hill-Sachs defect to engage into the anterior glenoid. So treatment for postgraduate students, if the patient has got a small Hill-Sachs lesion, which will not engage after anterior labral repair, just an anterior labral repair is enough. If the Hill-Sachs is big, and if that Hill-Sachs is going to engage after the repair anteriorly, an additional procedure called remplissage can be done, which can also be done arthroscopically itself by tenodasing the posterior capsule and infraspinatus into the Hill-Sachs, which is posterior. If the glenoid loss is more, then an anterior glenoid reconstruction procedure like latter J or iliac crest bone graft anteriorly has to be done if the glenoid defect is more than 25%. So
thank you, Bhupesh.
I think that will solve the answer.
Thank you, Bhupesh. Now I'll go to the faculty. And by the way, I mean, I might miss out somebody in the thing. It just unmute your this thing, and I'm looking at the screen. I will know, and I will call you. In that case happens. Now I'll go to the finished. I think I hope I have not left out faculty. Gopi, welcome. Dr. Gopinath joined. Dr. Ray, anything you want to add or anything you want to?
Dr. Rajgopalan.
Only one question.
Yes,
how it is helpful in a common shoulder problem, adhesive capsulitis, in advanced capsulitis?
Yes, sir. So capsular release of adhesive capsulitis is the last treatment when all other treatments have failed. Very good conservative management with capsular stretching exercises and mobilization exercises after giving adequate pain relief, either with shoulder blocks or intra-articular steroid injections is still a very good choice. Many of us have moved from doing mobilization under anesthesia to capsular release, because in mobilization under anesthesia, it is supposedly uncontrolled maneuver. And because the capsule is the tightest structure possibility of breaking it first without breaking other weaker structures like the rotator cuff or the labrum can happen. Although 80% of the time we have very good results with MUA, there is a small fragment of patients who have very poor results with MUA because maybe they have ended up with a proximal humeral fracture or a rotator cuff tear or a labral tear after MUA because the capsule is very tight. In these cases, selectively when you know the shoulder is very stiff, arthroscopic capsular release is a controlled maneuver with a radio frequency device. We can go in and release only the capsule followed by a subacromial decompression and which will give pain relief. And patient will have fantastic results on table. Even a gentle MUA after arthroscopic capsular release is also sometimes done because now you know you have weakened the capsule by releasing it and you will not go and damage the bone or other soft tissues for that matter. So it is a fantastic surgery, but since very good conservative management has come, the procedure has become less frequent among surgeons doing it. Otherwise, it is a very good surgery.
Thank you, Bhupesh. Dr. Manish, you wanted me to do something?
Yeah, I've not received any questions from the audience, so you can continue.
Okay,
And
okay.
sir, we are exceeding time, so we have to be slightly fast.
Yeah, I know. They are all when they are hungry, they will reduce the question. Dr. Shah, I'm sure you don't have a question, no, Shah. Manish has already given.
No, you can continue, no problem. Only in continuation with this, in frozen shoulder, if you're going to do arthroscopy, how much chance is there for recurrence of frozen shoulder itself? You've done a surgery for something and then you get it again. Then what's the use of doing it?
Sir,
question.
Yeah, no, I have to answer it honestly. I have not seen any literature which is giving us an exact number which will say so much is the recurrence chance. But in general, it gives good results. Very similar to EU mobilization under anesthesia minus the possible complications with it. So we are basically doing the same thing. And we can only offer so much at that given point. So if there's a recurrence, we have to handle it judiciously.
Good answer.
Excellent lecture, sir.
Control surgery.
Wonderful.
Good answer. Thank you, Dr. Bhupesh. Bhupesh, I wish you, if you are free to stay for,
Yes, sir. Surely, sir. Surely, sir. Sure.
It's a request from my side, Bhupesh.
Definitely, sir.
Unless otherwise you have commitments, Bhupesh, I understand.
I will stay, sir. Yes, sir. Thank you, sir.
Okay. Next, I invite Dr. Gopakumar to talk us about, for the students, now onwards are going to be cases, scenario. Gopakumar, meanwhile, you can load your slides. But now onwards, it is going to be more like a case scenario. The presenter will present it in either as a talk or as a case, but the whole idea is like that. This will be a Sprengel shoulder case, which Dr. Gopakumar will be covering. And next is...
Yes, sir.
Yeah.
Shall I start?
Gopakumar, please carry on.
First of all, I would like to thank the IOA PG team headed by Rajagopalan sir for giving me this opportunity to share some of my views regarding this Sprengel shoulder. The topic as such, it is a very rare thing. It is very rarely asked in the exam, especially in the practical exam. In my past 15 to 20 years of experience, I have only seen it being kept twice or thrice in the PG exams. So usually it will be a child like this coming through with this deformity. So this is an elevated scapula. This is often called as a congenital elevation of the scapula. But this term is a misnomer because it is a failure of scapula to descend from the level of C4 to its normal position. The normal position of the scapula is between T2 and T7. It is the commonest congenital anomaly occurring in the shoulder girdle. A little bit regarding the embryology, the development of the scapula starts between 4th and the 8th week of gestation, that is intrauterine life. It is located at the level of the 4th cervical vertebra. The scapula descends down by the 12th week of intrauterine life to its normal position, which I have already mentioned, between T2 and T7. The failure of this descent leads to a hypoplastic and elevated scapula. So what causes this? Nobody knows. Various theories are there. One is a vascular lesions arising from the subclavian artery distribution, leading on to a failure of descent. Sprengel himself thought that it is due to increased amniotic fluid pressure, and autosomal dominant inheritance have been reported, but most of these cases which we see are sporadic cases. Now, regarding the history of Sprengel shoulder, it was first reported in 1868 by Eulenberg in Germany, and it is named after a letter by Otto Gerhard Karl Sprengel in 1891. Actually, in the paper, it was Sprengel and Kollinger who described the lesion, and Kollinger gave the name of his elder Sprengel. The main classification system came in 1972, years after that, by Cavendish. So what is the pathoanatomy? It is just the continuation of the fetal form of the scapula. It is a small and deformed scapula. There is a horizontal diameter of the scapula exceeds the vertical diameter. Third, anterior curving of the supraspinous portion. Prolongation of the supromedial scapular angle. The omovertebral bar is seen in around up to 50% of cases. Then costovertebral defects, that is vertebral defects like congenital scoliosis and costal defects like refusion, all these are commonly seen. Omovertebral bone in 20 to 50% of cases, you can see it here. So it is a chondro-osseous structure. It is rhomboid or trapezoidal in shape. It connects the supromedial border of the scapula with the spinous process, lamina, or the transverse process of the cervical vertebra between C4 and C7. So it is attached to the spine and it is attached to the supromedial border. Always there may not be a continuation. Some part of it is fibrous or some part of it may be cartilaginous, and there may be a joint in between these two. It is best visualized in the lateral and the oblique X-ray. So scapular rotation is an important part. If the scapula just descends like this as in a normal scapula, there will not be any rotation. But if there is a medial tether, you can understand what is going to happen. If it is tethering, it starts rotating, and this causes restriction of abduction. Tethering superiorly will cause just an elevation of the scapula without any rotation. So it is the medial tethering that is responsible for rotation of the scapula, which actually this is wrong. It rotates in this direction, in the reverse direction, and therefore the glenoid will be facing downwards. This leads to the restriction in the rotation. What is the clinical problem which the child comes to you? The child comes to you usually with a cosmetic problem. The one side, there is asymmetry of the shoulder, and one shoulder is at a higher level. Or they may come with a functional problem. What is the functional problem? It is the restriction of shoulder abduction, and very rarely they will come with pain. What causes restriction of shoulder abduction? One is the forward, I have already said, the superior angle of the scapula is bent forwards over the apex of the thorax. Second, the inferior pole of the scapula is medially rotated, which I have already shown, with the glenoid facing caudally. Then some of the muscles are weak and absent and provide insufficient power of shoulder abduction. And the fourth is the omovertebral bone. These are the four causes by which cause restriction of movement of the shoulder. So the presentation is cosmetic or functional. Functional restriction of abduction, I have already mentioned what causes the restriction of abduction. Now coming to other clinical features, usually it is even though it is a congenital anomaly, it is not usually detected at birth, even if it is a mild lesion. It is usually detected in 1 to 2 years of age. It is common in females in the ratio 3:1. More on the left side, the reason is unknown. It can be bilateral, and unilateral lesions produce more cosmetically unacceptable, while bilateral lesions are more cosmetically acceptable but functionally disabling. On the general examination of the child, always look for a short neck, because these Sprengel shoulder is associated with several other problems like Klippel-Fehl anomaly. Therefore, a short neck may be there. There may be a low hairline. There may be webbing of the neck. There may be torticollis. Usually, the neck will be tilted towards the side of the Sprengel shoulder. There may be a dorsal scoliosis or a lower cervical scoliosis, which may be congenital scoliosis. There may be costal asymmetry, that is asymmetry of the thorax. There may be facial asymmetry, plagiocephaly. There may be spinal dysraphism. This spinal dysraphism may be at a lower level. In the lower lumbar spine also, you can see lesions like diastematomyelia, which has been reported. In the local examination, always look for the contour and the symmetry of the shoulder. By inspection itself, you can find that the shoulder is asymmetric and the contour is different. Then you look at the position and the size and the orientation of the scapula, whether there is any scapular rotation. Then the scapular hypoplasia will be there. Scapula will be at a higher level and scapula may be rotated. This is often described as a shear lesion. Scapular hypoplasia, elevation and rotation. Omovertebral bone may be palpable. If you palpate in this area, you may be able to feel a bony resistance. Wasting of the muscle is not very common, but may be seen. But congenital absence of some muscles like pectoralis major may be seen when it is associated with Poland syndrome. And usually there will be some hypoplasia of the whole of the upper limb. So you don't forget to take measurements of the upper limb and compare with that of the opposite side. Now you look at the movements. There will be a restriction of movement. Here you find there is restriction of movements, but reasonable amount of movements are usually seen. Active and passive movements are usually the same. And another thing is the scapular elevation sign, which will come to in the next slide. It will be negative. And normal glenohumeral movements will be there. And there will be severely restricted scapulothoracic movement because the scapula is rotated and it is not moving. So 30% of the movement is contributed by the scapulothoracic joint. That will be affected. But the glenohumeral joint is usually having reasonable range of movements. The scapular elevation sign is the prominence of the scapula change with various movements of the shoulder. This you might have seen in cases of brachial plexus palsies. You might have seen the so-called putti sign. The subscapularis, when it is contracted, and if you externally rotate, the scapula becomes prominent. When you externally rotate and abduct the shoulder, if the contracted muscles are teres major and latissimus dorsi, again the scapula becomes prominent. If the pectoralis major is contracted pectoralis major is an adductor. Therefore, if you abduct the arm, the scapula becomes prominent. Teres minor and infraspinates are external rotators. So if they are contracted, the opposite movement, the scapula will become prominent and elevated. And supraspinatus, if you adduct it, again the scapula becomes prominent. So this scapular elevation sign usually will be negative. I have concentrated on this because if you get a shoulder case where the diagnosis may be a little different, that is a brachial plexus birth palsy, these signs may be positive. You look for other anomalies. Vertebral anomalies, usually don't forget to look at the back for a spina bifida or a scoliosis, which may be due to a formation defect or a segmentation defect. Look at the rib cage, whether there is any asymmetry. There may be rib anomalies which can only be seen in X-rays. Muscles may be hypoplastic, fibrotic, and absent. The usual ones are the trapezius, rhomboides, levator scapulae. But other muscles like serratus anterior, pectoralis major, all these muscles may be hypoplastic or fibrotic. Associated anomalies in the spinal cord may be seen. And usual thing is diastematomyelia, which has been reported initially by von Baesen, and it is commonly seen. The tethered cord syndrome is another association. There may be cleft palate and lips, camptodactyly, and renal and agenesis and pulmonary problems. So many anomalies may be seen. Cardiovascular problems may be seen. So a systemic examination again is important. There are several associated syndromes. If you look at the textbooks, there is a lot of syndromes reported. But the common ones are the Klippel field, which is a triad of cervical vertebral body fusion, low hairline, and the short leg with limited range of movement of the neck. Poland syndrome, which I have already said, absence of pectoralis major, along with syndactyly, or water syndrome, the vertebral anal, tracheoesophageal and renal anomalies, which is commonly associated with radial club hand, and Charcot-Lewin syndrome. It is nothing but a spondylocostal dysostosis, which has occasionally been reported. There has been a report from KMC Manipal also. It shows multiple vertebral segmentation defects and anomalies. Now coming to the classification, Cavendish classification is a clinical classification which tells you how much the shoulder is at a higher level compared to normal. Grade 1 means shoulder joints are at level and deformity is not visible when dressed, or a slight elevation may be seen. Scapula may be elevated, but the shoulder is at a same level. Shoulder joints are at level. The deformity is visible when dressed as a lump in the web of the neck. There is no elevation of the shoulder as such, but only the scapula is elevated. Grade 3 is shoulder joint is elevated 2 to 5 centimeters and deformity is easily visible. And grade 4 is the severest variety, where the superior angle may be at the level of the occiput, much higher, with webbing of the neck and short neck. Investigations, X-ray alone is necessary to make the diagnosis. And here you can see both the elevated and broadened scapula, a rotated scapula, along with the omovertebral bone. Always don't forget to look at the omovertebral bone and look at the whatever spine is seen, you look for any anomalies. In the rib also, you look for anomalies. 3D CT again helps you to find out the scapular shape and the omovertebral pad. When you take a 3D CT, you will be able to see it very well. This is the bar which you are seeing here, which is clearly visible here. What's the role of MRI? In some fibrous and cartilaginous omovertebral bone, bar can be seen. But the main thing is you have to do a screening of the spine to look for spinal dysraphism, especially diastematomyelia, which is seen at a lower level. Radiological classification has been described. And again, it is not of much importance. It just shows how much the scapula is elevated. Grade 1 means the supromedial angle lower than T2, but above T4. Grade 2 means supromedial angle between C5 and T2. And grade 3, it is above C5. This indicates just the severity of the elevation of the scapula. Now, differential diagnosis, actually in a severe case of Sprengel shoulder, there is no differential diagnosis. You can make, it is a spotter and you can easily make the diagnosis. But in mild cases, you have to exclude brachial plexus birth palsy, deltoid contracture, infantile hemiplegia, and osteochondromas of the scapula. In brachial plexus birth palsy, there will be history of difficult labor and shoulder dystocia, history of flaccid paralysis after birth, shear, that is deformity, scapular hypoplasia, elevation and rotation may be seen. The passive movements will be more than active movements because of muscle weakness. The scapular thoracic movements are unaffected, while in the case of the Sprengel shoulder, it is the scapulothoracic movement that is affected. And scapular elevation sign, which is negative, becomes positive here. It is positive in brachial plexus palsy, while it will be negative in Sprengel shoulder, and muscle weakness is more prominent in brachial plexus palsy. The other diagnosis, which is rare nowadays, is the deltoid fibrosis. Usually it is due to injections given onto the deltoid. So it produces scapular malrotation. The scapular elevation sign is positive. It's usually, since the deltoid is the abductor, when you adduct the arm, the scapula becomes prominent. That is how you diagnose that, and you will be able to feel the fibrotic band also. The scapulothoracic movement again is not much affected here. Infantile hemiplegia like cerebral palsy, very rarely mimic this. You can look at the typical history of prenatal problems, prematurity, low birth weight, neonatal asphyxia, convulsion, all this. Then shoulder is adducted and internally rotated. Internal rotators and adductors are spastic. Abduction and external rotation movements are limited. and lower limb involvement may also be seen. A more common differential diagnosis may be an osteochondroma underneath the scapula. Here, it is usually seen in cases of hereditary multiple exostosis, so the family history may be present. There is no shear deformity. The scapula is of normal size, shape, and it is not rotated. Active and passive ranges of movements are the same, unlike in the case of birth brachial plexus palsy. Scapular elevation sign is again negative, and you will be able to feel the bony mass on the proximal humerus or the scapula. Now, regarding the treatment, years back when I was doing my post-graduation, at that time there was one Barbados fast bowler called Gladstone Small, and seeing at the picture, it appears as if he was having a bilateral Sprengel shoulder. So usually during the discussions, the consultant used to tell us, so if Gladstone Small can become a fast bowler, what's the need of doing surgical treatment for this condition? So surgical treatment is rarely indicated, but if there is a severe cosmetic deformity or a severe functional deformity that is limiting abduction of the shoulder, definitely there is an indication for doing surgical treatment. Ideal time, it is usually done between 3 to 6 years of age. Most of the reports say that it should be done during this period, but Tashian in his book says it can be done at 6 months. But there are several others, including from India, who are doing this even in older children. So indication, the functional problem, cosmetic problem, usually for Cavendish 3 and 4. The goal of surgery is for cosmetic and functional improvement. Associated abnormalities such as torticollis and congenital scoliosis limit the amount of correction. Bilateral deformities and grade 1 deformity usually do not need surgical treatment. Patients with grade 4 deformities should be offered a guarded prognosis because the scapula is lying at a very high level, and therefore bringing it down may cause nerve palsies, and you will not be able to bring to the normal level, but you may be able to bring down to a substantially at a lower level. The surgery may be avoided in patients with short neck and concomitant grade 4 deformity. What surgery will we do? In mild lesions, these are the 2 surgical procedures that can be done. There is excision of the omovertebral bone and excision of the supromedial angle of the angle and the omovertebral bone. These surgeries can be done and it improves the cosmosis. And when the omovertebral bone is removed, it improves the range of abduction also. So in mild cases, you can get away with this. The other method is scapular transplantation at a lower level. That is 2 procedures that have been described as the Woodward procedure and the Green procedure. I don't think at the postgraduate level, you need to know a lot about these surgical procedures, because these are done only by a few surgeons in specialized centers, not routinely done in all the hospitals. Other options are subtotal scapulectomy and scapular osteotomies. So you just need to remember this, and you to know a few the principles of scapular transplantation. So the basic difference between the Green procedure and the Woodward procedure is that Green erased the muscle from the insertion of the scapula, while in the Woodward procedure, it is erased from the origin. The steps are: 1, osteotomy of the clavicle. In severe lesions, you do a morselization of the clavicle, that is, cut the clavicle into multiple pieces and put it back in the periosteal sleeve. With this reduces the incidence of brachial plexus palsy. You detach the trapezius from the insertion to the spine of the scapula, erase latissimus dorsi, then you detach levator scapula and rhomboides. So all the muscles attaching onto the scapula apart from the lateral border are now erased. Then you elevate the scapula and detach serratus anterior if required. Now you bring the scapula to a lower level and attach it to the ribs, and then you repair the muscles. In the Woodward procedure, you erase the muscle from the origin and again detach the muscles, trapezius, rhomboides, levator scapulae, remove the omovertebral bone. The prominent bony portion can also be excised, that is, the supromedial portion can also be removed. The scapula is pulled downwards and muscles are reattached at a distal level. And these surgeries are not without complications. Brachial plexus palsy have been reported, and this can be reduced by a generous clavicular osteotomy or clavicular morselization. Nerve injuries like injuries to the dorsal scapular nerve, spinal accessory nerve, and suprascapular nerve have been reported. And scapular winging, even after surgical problem, you have brought the scapula down, but it produces winging. That again becomes a cosmetic problem. Another cosmetic problem that is associated with this is keloid formation. These are the common surgical procedures and the problems associated with that. And as I have already said, you need to do, you as postgraduates, you need to know only the principles of treatment. As in a mild lesion with omovertebral bone, you just remove the bone. If there is a cosmetically supromedial border is prominent, you excise that. In severe lesions, that is Cavendish 3 and 4, after explaining the risk to the patient, if you are working in a center where this is routinely done, you can try for bringing the scapula down. Thank you very much. Thank you, sir.
I agree that's not a common, it's not a very uncommon. I also have not seen it being FO exam, but it is asked as a short note question in the theory. That's one possibility. So for a very informative talk, thank you. Now onwards, we will probably go, Gopama, you can share out of the screen. Well, the next speaker gets ready. Can we have, before I go to everybody now, general, anybody from the faculty or the panelists or office bearers who want to ask anything?
So can I ask a question?
Yeah, please, sir.
Yeah. One common question which can be asked to the postgraduates is, what are the common causes of winging of the scapula? Winging of the scapula. So
that will be given in the next talk, sir.
We have the next talk, sir.
Okay, fine.
Anybody else?
I have one question.
Yeah, Pasadi.
Yeah, thank you for this excellent talk. But one thing I must include that the pathophysiology should be kept in mind, because while doing the examination, we should know the condition of the muscles around the shoulders. That is in pathophysiology, it occurs in the 9 to 12 weeks of gestation. And there may be some trapezius, rhomboid, and devastator scapulae muscle may be absent or hypoplastic. The serratus anterior muscle may be weak, leading to winging of scapula. And other muscles such as pectoralis major, latissimus, or sternocleidomastoid may be hypoplastic and similarly. But this is the thing that I want to say, that this should be kept in mind while doing the examination part, and this will help. Thank you, sir.
Thank you, Pata.
Can I
Dr. Sibin, can you share your screen? You can ask your question also, yes.
Gopama sir, it was a quite informative talk, sir. Congratulations. Sir, just want to know, this putti sign seen in brachial plexus palsy, is it the same as the scapula elevation sign?
No, the putti sign is due to the contracture of the subscapularis.
Only alone, okay.
Yeah, subscapularis alone. And when you subscapulary, you externally rotate. Subscapularis is an internal rotator. So you do the opposite movement. Then you find that the scapula is projecting out. Then you call it as putti sign. But any muscle that is contracted, if you do the opposite movement, you will get an elevation as well as the rotation of the scapula and prominence of the scapula.
Right. Thank you, sir.
Anybody else? Dr. Chinmay? Yes, Dr. Ray, please, Dr. Ray.
Only one comment is that the patient, apart from cosmetic problem, the patient functional problem arises only if there is a omovertebral bone, I think so. Then the patient becomes very much symptomatic and problem. Otherwise, the patient accepts everything so far the function is concerned. Is it such, Professor Gopama?
Actually, nowadays, if you listen to the, I'm not routinely doing this. I accept excision of the omovertebral bone. I have not done any procedure. But if you listen to the webinar in POSI, where there are centers where it is doing it, they say that more and more children with the unilateral Sprengel shoulder is coming for treatment because of the cosmetic problem. The functional problem arises, as I have said, because of 4 reasons. One is the omovertebral bone. Second is the supramedial border of the scapula. 3, the rotation of the scapula so that the glenoid is facing downwards. And 4, as Sir said, the weakness and hypoplasia as fibrosis of the muscles. So these are the 4 problems that produce functional limitation for these children.
Okay.
So
thank you, Dr. Gopakumar. Anybody else, any other faculty or panelists, or Dr. Shah or Dr. Anybody want anything?
It was an excellent, complete presentation. That's good. Gopakumar, you know.
Thank you.
Thank you.
We'll now go on to Dr. Sibin. He will talk on scapular winging, how to evaluate. Thank you. Dr. Sibin, please. Meanwhile, Manish, any questions so far to any of the talks so far? Okay, Sibin, please carry on.
Sir, the screen is shared. Is it seen?
Yes, we can see you.
Good evening to one and all. First of all, happy Teachers' Day to all the faculties, distinguished panel of faculties. I would like to thank the Indian Orthopedic Association for giving this opportunity to present in front of this august audience. And I congratulate Professor Rajagopalan sir for taking on this initiative to teach the residents in these difficult times. Moving on to my topic, scapular winging, as you all know, is not a commonly present clinical case, but if it is present classical case, being though rare, if it is there, it can be kept as a short case for scapula from the shoulder section, as well as it's an important point from the theory point of view. And it's a little confusing topic when you think about scapular winging. And all thing that I knew during my residency was that only serratus anterior palsy produces, and only test to know it is the wall push test. So it's a little more than that. And to understand it, you need to understand the pathoanatomy behind it. So in the coming few slides, I will be discussing you what is the basic anatomy or the pathoanatomy that leads to scapular winging. What are the types? What is the etiology? And examination followed by management. It's basically defined as an abnormal prominence of the medial border of the scapula. And why is it so important? Because the scapulothoracic motion, as we all know, contributes to 1/3 of the shoulder motion. 2/3 is by the glenohumeral and 1/3 is by the scapulothoracic. So whenever anything affects the scapulothoracic, the glenoid motion is affected. Now going to the anatomy of there are around 14 muscles that stabilizes the shoulder joint. Out of that, 6 work on the scapulothoracic joint. And in this, among the 6, the most important one that are important from the point of treating or knowing the anatomy is the serratus anterior, the trapezius, and the rhomboids. These are the main 3 key muscles that you need to know in detail. So whenever you get a case of scapula, the one question that can be asked is what are the normal scapular motions? So it's a little confusing thing, but if you can see on my hand, there are 3 motions and 2 translations. So suppose this is a scapula, and the 3 motions are, if there is an anteroposterior axis, so there is an anteroposterior axis, along with the scapula can tilt up and down. So there is one motion. There is an vertical axis along the medial border, along with the scapula can go internal rotate or external rotate. And one more axis is the horizontal axis along the spine of the scapula. Along with the scapula can anterior tilt or posterior tilt. So I think along the 3 axes, you have got 6 movements. Anteroposterior axis, you have got internal up and down. Along the medial border or a vertical axis, you have got internal rotation, external rotation. Along the horizontal axis, along the spine of the scapula can anterior tilt or posterior tilt. So these are the basic 6 motions in scapula. Then there are 2 translations. Translations mean the whole scapula moves. The other case, it only rotates along a single axis. In the translation, there can be upward translation or downward translation or a sliding, or it can be anterior translation, otherwise called as protraction, or a posterior translation, that is called as a retraction. So there is in total, you have got 10 movements happening in the scapula, and these are responsible for producing the whole composite movements. I think it is clear regarding the movements of the scapula. Now going to the anatomy of each muscles, the most important muscle is the serratus anterior, and what you need to know is that serratus anterior, there are 3 basic main parts of the serratus anterior: the upper, the middle, and the lower. The middle one is the most important one that produces protraction. Protraction means anterior sliding. Okay, the protraction is produced by the middle part. As you can see, the lower part, when it contracts, it produces upward rotation of the glenoid. as you can see from the picture, when the upper part just stabilizes the scapula. So the middle and the lower part are the most important things. And the scapula is supplied by long thoracic nerve, which is arising from the brachial plexus. So you get scapular paralysis or a serratus anterior paralysis in brachial plexus palsy. And what is important from the treatment point of view, you should know, the PGs or the residents must be knowing the surface anatomy of the long thoracic nerve. It runs along the mid-axillary line, around 25, it's around 24 centimeters long, and it's a pretty superficial nerve. So that's all about serratus anterior. Going to trapezius, it's similar to serratus anterior. It has divided into 3 parts, the upper, middle, and the lower. The middle is the most important part. As you can see, the middle one acts opposite to the serratus anterior. It retracts the scapula, or a posterior translation. So retract the scapula. The upper part just elevates the scapula. There is upward rotation and elevation. The lower part downward. So all 3 things act in synchrony to produce the typical movement, upward movement. Okay, and it is supplied by the spinal accessory nerve. An important point from the spinal accessory nerve that it's the spinal accessory nerve goes through the posterior triangle of the nerve. And it supplies the spinal accessory also supplies the sternocleidomastoid. These are the 2 muscles supplied by the spinal accessory nerve. Going to rhomboids, the main action of the rhomboids, as you can see, it is also retraction, just like the trapezius. It also retracts the scapula towards the midline as well as elevation because of the direction of the fibers, as you can see here. It's supplied by the dorsal scapular nerve, again a branch from the brachial plexus. It's a root value C5. Going to the rhomboids, the levator scapulae, this is not an important muscle from this winging point of view, but it assists the trapezius. So it better to know it basically acts to elevate the scapula. It has nothing to do with protraction or retraction, and is basically supplied by dorsoscapular and C34 nerve fibers. Coming to the classification of winging of scapula, you can classify the scapula based on either the displacement of the scapula or based on the etiology. So based on the displacement, the medial, it can be either a medial winging or a lateral winging. That means medial winging means the whole of the scapula is going to medially. The medial portion of the scapula moves towards the spinal vertebral column. Lateral winging means goes away from the vertebral column. So medial winging happens when the lateral, the protractors or the serratus anterior is weak. So when the only protractor that is there is the one is a serratus anterior. So if you have serratus anterior weakness, the whole of the scapula comes medially, you get a medial winging. And due to the pull of the opposite trapezius, the medial border goes up. So the scapula position will be displaced more medially as well as upwards. Whereas on the lateral side, when the lateral winging means there are 2 things that prevents lateral winging. It can be either a trapezius or a rhomboid. So if you have a trapezius weakness, again lateral goes laterally. But in this case, because trapezius is attached on the upper part will be more laterally shifted than the lower part. Whereas in case of a rhomboid, it's attached to the lower half of the scapula. The lower half, when it gets palsy, lower half will be going more laterally than the upper half. Upper half will be tethered by the trapezius. So that's the inferior and superior angle. So we will see in further slides what's the basic difference between the 2 winging. From the etiological point of view, it can be primary, secondary, or voluntary. These are things. The most important primary causes are the neurologic causes, where you can have injury to the injury or at any sort of injury to any of these primary nerves. It can be osseous due to the osteochondromas or a fracture of the inferior pole of the scapula. It can be soft tissue lesions like muscle avulsions, serratus anterior avulsions, or bursitis. Secondary causes of the winging are any pathology affecting the glenohumeral or subarachnoid can produce a secondary weakness of the glenohumeral, the scapulothoracic muscle, and result in winging. Another important cause is a muscular dystrophy. That's not so common thing. Facioscapular humeral dystrophy is the classical one that produces winging. And the last one is the one that you should recognize is the psychological cause of winging. Just like you have a voluntary dislocators of the shoulder, there are people who can voluntarily wing the shoulder. So you should be identifying those patients from the history as well as examination and not jump to treat the patients. Now going to each palsy, what is the etiology of each palsy? Each palsy can be traumatic, non-traumatic, or idiopathic. But primarily, it's always majority commonest is the neurogenic cause. What are the traumatic neurogenic causes? The commonest for serratus anterior palsy is traction on the nerve, and that is repetitive stretching. That can happen in athletics or overhead workers where you hyperabduct the shoulder and produces stretching of the long thoracic nerve. It can happen due to compression by trauma or contact sports, or compression sometimes happening in the scalene triangle, or sometimes by subcoracoid bursa when it gets inflamed. So these are compression causes. Or other common thing that you can see is laceration during your iatrogenic acts during the surgery. As I told, it has a long subcutaneous course along the chest wall. So any surgery around the axilla or or near the thoracic wall, like mastectomy, or even a simple chest tube putting, if you are not correct position in the mid-axillary line, it can damage it. or sometimes abnormal positioning, long abnormal positioning, hyperabduct shoulder in the lateral position can also lead to scapular winging or due to palsy of the long thoracic nerve. The commonest non-traumatic cause for neurogenic cause is the Parsonage-Turner syndrome, otherwise called as a neuralgic amyotrophy. Commonly, the neuralgic amyotrophy involves axillary and suprascapular nerve also, but in around 20% of cases, there may be isolated involvement of only the long thoracic nerve. And as I told you, the root value of long thoracic nerve is C5, 6, and 7. The 7 is the major contributor. So in all the cases with C7 radiculopathy can have an element of winging with them. Going to the myogenic cause, these are rare ones, like traumatic avulsions or dystrophies, and osseous ones are due to the fractures of the inferior pole or malunited scapular fractures. The same etiology applies for trapezius palsy. Here also, primarily it's basically neurogenic, and unless proved otherwise, 90% of times it is iatrogenic, because as I told you, the main cause of the nerve is in the posterior cervical triangle, and one of the common surgeries performed there is the cervical lymph node biopsies. So, and it's usually done by the junior residents, and who are unaware, and that can usually lead to the damage to the spinal accessory nerve. It can be damaged by trauma or from penetrating injury like in assault, etc. Another important point where rarely you can find this is a mononeuropathy. How can you differentiate the two? Mononeuropathy affects the whole nerve. So you have weakness of not only the trapezius, but you have weakness of the sternocleidomastoid also. This can be seen in Arnold-Chiari or Guillain-Barré syndrome, though rare. Rhomboid palsy again follows the same dictum. It is primarily neurogenic, but commonest cause is entrapment of this nerve within the scalenus medius. The C5 root comes from the scalenus medius, and the entrapment neuropathy is the commonest cause. Similarly, the root value is C5. Any cause producing C5 radiculopathy, like a disc prolapse, can lead to weakness. Rarely you can find the traumatic ruptures in volleyball players. So that causes the primary etiology. What are the secondary causes? You name any condition around the shoulder joint that affect the glenohumeral joint, be a bony cause or a soft tissue cause, it can produce a secondary winging. It can be a rotator, common things like rotator cuff, shoulder instability, malunited clavicle fracture, anything. All the listed conditions can produce as secondary weakness of the periscapular muscles, resulting in winging. How does the shoulder patient present to you? Basically, it's a very vague and non-specific complaints patient presents. They say that there is a pain in the, got some non-specific pain in the base of the neck, scapula, or upper shoulder. Sometimes they come a cramping pain in the interscapular muscles, or they complain weakness when do overhead activities, because the scapula is needed for, as I told you, overhead activities. And if there is a medial winging, the patient complains of discomfort when they are sitting across a chair or long sitting in a car, because the medial prominent border gives some discomfort. And many complain of subjective shoulder instability, although classical features of that will not be there. So in the history, as I told you, you have to ask for the history of any surgery, any recent viral illness, and ask for history of all the secondary causes. That can be from the glenoid or subglenoid, subacromial area. Going to inspection of the patient, always do the routine shoulder examination. As has been told previously in other classes, always examine the patient from the back. You have to strip him up to the waist and then see for the winging. Always compare the scapular rhythm on both these sides. If there is a winging at the rest, compare medial prominent winging at the rest, which increases with forward flexion or abduction, you are dealing with a medial winging caused by serratus anterior palsy. There is not much winging seen at the rest, but winging appears with abduction or extension movement, you are dealing with a lateral scapular winging that is due to trapezius or rhomboids. And you can get a non-specific pattern of winging if there are secondary causes or voluntary dislocators. So these are the basic three patterns how you can identify winging, what type of winging you are dealing with. Always examine in multiple movements. You have to multiple times you have to abduct and forward flex to see the correct, identify the correct pattern of the winging. Look for any wasting of the periscapular muscles if there, and do the scapular compression test that I will describe in the coming slides. So here you can see the basic examination. You start, go for the complete forward flexion. You do it multiple times, look for the medial border, whether it is going medially. Here you can see on the lateral side, on the left side, the medial border is getting more prominent. And so that can be told as a winging. Here also, multiple times you go, abduct and bring down, do that and look for compare the scapular rhythm on both the sides. Going to palpation from the inspection, palpate the periscapular muscle, you will find tender spots along the medial border or supromedial border due to the overaction of these muscles. And sometimes you can feel crepitus if the cause is like something like a scapulothoracic bursitis or an osteochondroma, as already been described by Gomez sir. The most important part in palpation is examination of these three key muscles. This is the one thing that is always asked in your examination of serratus, trapezius, and rhomboids. Sometimes sternocleidomastoid. Do the routine examination shoulder and neck because to rule out the secondary causes. And from the movement point of view, usually you find the passive movement, active movements are lesser than the passive movements. And only unlike the shoulder pathology where you get rotations are affected more than the flexion and abduction. Here in this case, flexion and abduction is more affected than rotations. Okay. So from the measurement point of view, you can draw the medial border and you can measure the distance of the spine of the scapula, which is usually at the level of T3, or the inferior angle, which is at the level of T7, and compare it with the opposite side and see that whether it's a medial winging or a lateral winging. That's on the measurement. Now going to the specific palsies, as I told in serratus anterior palsy, you get a medial winging at rest, which accentuates with forearm flexion, as you can see in the picture down. And usually arm flexion not more than 120 degrees possible because due to the lack of upward scapular tilt. And scapular stabilization usually corrects the movement. What are the tests you need to do? The first test is the patient is able to stand, do the standing wall push-up test. When your patient pushes the wall, because of the lack of protraction by the serratus anterior, the medial border of the scapula becomes prominent, as you can see here. So in this test, this is the way to do the scapular protraction. In this case, the test is negative, but see both the sides of scapula. And if it is not positive, you can ask him to flex the elbow multiple times and extend and do that routine push-up and check for whether the muscle gets fatigued and that develops a weakness. Okay, so these are the things you should follow when you're doing a Walsh test. Another test that you can do either in sitting or standing is the forward elevation test. As I told, the forward elevation beyond 120 degrees is mainly by the scapulothoracic and action. So ask the patient to abduct the forward flex more than 90 degrees, and while palpating at the same time, palpate the serratus. Okay, so that's the way to do the forward elevation test. Another test that can be done in supine positions are ask the patient to protract the arm against resistance. But the only negative point is that you can't feel the medial wing, you can't see the medial winging, as you can see, but you can always feel for the action of the serratus anterior. So this is commonly done. Another common question asked for serratus anterior testing: how do you test in a brachial plexus palsy when the patient is having a flayed limb? So in this case, you can't do a wall push-up test, or you can't ask the whole limb is flayed. So what you can do is that you can make the patient sit up over a chair support, arm is supported on a chair, it's an assisted protraction, and ask the patient to protract while feeling for the serratus anterior action. If he is able to protract against gravity, negating gravity, against gravity, you can test by looking and doing in the supine position, as we have already demonstrated. So that's the way one you can do. You can do the same thing in the sitting position also. You do protract against resistance. That is what you do. Just protract the shoulder instead of the whole upper limb. You protract and look for winging appearing or not. So that's the way you test in when the upper limb is flayed. Going to the next thing, trapezius palsy. Here you can see the right side. You can see there is evident drooping of the shoulder. The winging is minimal at rest, as I told. The winging accentuates when the patient abducts the arm, as you see in the lower picture. It's basically a lateral winging. And as you can see in this picture, in the lateral winging, because the trapezius is attached to the upper half, the superior angle will be more laterally displaced than the inferior angle. This helps you to differentiate from it from the rhomboid palsy, where the inferior angle will be more displaced than the superior angle. Hope you got the point, because of the attachment of the two things. And usually because the scapula is not tilting upwards, you will get an impingement on overhead activity. So patient will present with features of overhead impingement. Okay, and always better to test sternocleidomastoid because both have got a same nerve supply to rule out whether the lesion is distal to it or proximal to it. So this is a case of evident case of trapezius palsy. As you can see, this is the spine, and this on the right hand side scapula, the upper border is more laterally placed than the inferior angle, and aggravates the deformity aggravates with abduction. So that's a lateral scapular winging classically for trapezius palsy. And the clinching point is you look at the neck of the patient, you find a scar mark of lymph node dissection. It's a small mark, but if you miss the point, that's the whole the diagnosis you can go wrong. So always look at the neck. The patient may not be remembering also sometimes because it was done under local anesthesia. Okay, so always check for this point when you're dealing with a case of lateral winging. What are the tests you do? The common trapezius test you have test for all three groups, and additional test can give you additional marks like resisted external test or a triangle sign. So the upper trapezius you test by flexing the neck laterally, as you can see in this video, and just giving the resistance in the opposite direction. So you can feel the whole bulk of the trapezius. Coming into the middle trapezius, how do you test? That is tested in the mid prone position. Arm is abducted 90 degrees, and ask the patient to extend the arm. And where at the same time you feel for the bulk of the muscle mass of the trapezius. The only thing you should keep in mind is that the arm should be in external rotation. That means the palm should be facing up. That only you will be testing the trapezius. Otherwise, you will be testing the rhomboids. So palm facing up, 90 degree abduction, extend against resistance, feel for the muscle bulk. How do you test the lower trapezius? Hyperabduct the arm more than 90 degrees, and with the palm facing up only, try to abduct against resistance, extend against resistance. So you can do it with the flexed elbow also. With doing it with a straight elbow is painful. The same maneuver is pointed out. Here you can see, you can feel for the trapezius, the palm is facing up while giving resistance in hyperabduct position. So that's for the lower trapezius. The additional test that you can give you an additional mark is the resisted active external rotation test described by Peter Stan. That basically what you do is that you external rotate, just like you're testing the infraspinal test, and look posteriorly. Posteriorly, if the middle border gets prominent, the middle border usually stabilized by the trapezius and rhomboids. If they are not working, it gets prominent, and that's a positive test. That's called as a resisted active external rotation test for the trapezius. Third thing is a sign described by Offer-Levy from UK. It's a triangle sign. As the patient is unable to extend, abduct it fully, forward flex fully, compared to the opposite side, you'll make a picture like a triangle gap will be seen in a prone position. That's a triangle sign. These are two additional signs for trapezius palsy. For the sternocleidomastoid, we all know that it's very easy to test. If you want to test the right side, ask the patient to look at the opposite side and give resistance. You can feel for the tautness of the sternocleidomastoid. Going to rhomboid palsy, this is the least subtle or the most subtle winging of the scapula. Usually, as I told previously, the lateral angle is more rotated laterally. Inferior angle is rotated more laterally than the superior angle. It extends and increases when the patient extends the arm, because the action of the rhomboids is basically to extend the arm and adduct the arm. So that is a position when it extends, and when it accentuates. And usually you don't see the wasting because it is covered by the trapezius, the hypertrophic trapezius. So the way to test is, you ask the patient to hold his arm on the waist, as you see here in the picture. And that's the area where you had palpate for the muscle. And give force against, ask the patient to adduct and extend, giving resistance in the opposite direction. As you can see here, you feel for the rhomboids, keep the hand over the waist and ask the patient to adduct against resistance. You can feel for the rhomboids. Another way to test the rhomboid is in a prone position. This is the same way as you test the trapezius. Only thing is that the arm is in internal rotation. That means your palm is facing down. The palm is facing down, that means then you are recruiting more of the rhomboids than the trapezius. Mind you, both have got almost similar action. So it's to recruit one muscle more than the other, you change the position of the arm in internal rotation and external rotation. Now, what is scapular thoracic test that I was describing previously? Now you see, this is a patient who has got a middle winging. When she is asked to elevate, forward flexion is restricted. But when you compress the scapula towards the chest wall, as you see here, she is able to elevate it fully. So this is called as a scapular compression test. That is a test for choosing the patient for surgical stabilization. If the test is positive, that means if you surgically stabilize the scapula to the thoracic wall, she will improve clinically. Otherwise, the patient is not selected for surgery. So this is an important test when you're deciding for surgical treatment. Now coming to pseudo-winging, what do you mean by pseudo-winging? Pseudo-winging means winging usually is not due to the classical neurogenic or muscular causes. It is due to some mechanical causes like osteochondromas or malunions. The winging usually doesn't change when the arm position is varied. And all the muscle functions, EMG, etc. are normal, and you can easily diagnose it by X-rays or CT scan. So what are the investigations for winging of the scapula? Depending upon the etiology, what you find. If you are thinking in lines of a bony malunion and osteochondroma, take X-rays or CT scan. If you are thinking in lines of a neurologic cause, like a disc or something, take MR. A shoulder cause, you want to rule out a shoulder, secondary cause in shoulder or subacromial area, you take the MR scan, and so on. And the important, the thing to diagnose primary causes of scapular winging, you do the EMGs of the respective muscles and the nerve conduction test. Now coming to the management as a whole, if you ask, the management is usually conservative unless it is an open injury or something like that. Usually and prolonged conservative treatment. It's not for 2 to 3 months, it's 6 to 18 months. Sometimes up to 24 months you can treat conservatively before interfering with surgery. Okay, and sometimes some people give scapular brace, which compresses the scapula against the thoracic wall, just like a scapular compression test we have done, and that will improve the movement. Operative treatment is basically if the nerve is engulfed in a fibrous tissue or something, you do neurolysis. Sometimes you can do a nerve transfer. And if it is a muscle avulsion, traumatic avulsion, early repair is indicated. But the common treatment that you do after failure of your long conservative treatment is the stabilization of the scapula. This can be done in 3 ways. You have to stabilize the scapula to the rib wall. Either this is commonly done using a muscle transfer. The commonest done is the sternal head of pec major. The sternal head of pec major has the same action, almost is a agonistic muscle like the serratus. So you transfer the sternal head of the pec major to the inferior angle. So when it pulls, the the glenoid faces up and it compresses the chest, it against the chest wall. The second surgery is you can use facial slings to attach the scapula to the chest wall, but usually leads to failure because it stretches out. And the final treatment that everything fails out, the salvage option is you fuse the scapula to the thoracic wall. That's the scapular-thoracic fusion. That's the final treatment for this case, usually done for cases like humeral muscular dystrophies. Coming to trapezius palsy, again, conservative line is the first line of management, but usually less response to conservative thing. And surgery, similar, if it's a nerve issue, you do go for neurolysis. If nerve cut is there, you do for suturing, otherwise grafting. And the operation that you do to stabilize here is the Eden-Lange muscle transfer. That means you transfer, these are the rhomboids have got the same synergistic action like the trapezius. So increase the lever arm of these muscles by transferring them more laterally toward the spine of the scapula. So as you can see, the almost similar action, you transfer the levator scapula as well as rhomboids more laterally so that they have the action like a trapezius. In rhomboid palsy, majority are treated conservatively because it has got a similar action as the trapezius, which is a much bulkier muscle. So you need to only strengthen the trapezius in these cases. Rarely is the surgery needed for rhomboid palsy. So to conclude, when you are dealing with the case of a winging of scapula, the most important thing is take a good history to know whether it's a primary, secondary, or voluntary case. If it is a primary case, most common cause is the neurological cause, is long thoracic nerve palsy, the commonest, followed by palsy of the spinal accessory nerve, which is usually iatrogenic. Iatrogenic following neck surgeries. Always examine the patient from the back, compare the two scapula for the scapulothoracic rhythm. Find out whether it's a medial or a lateral scapular winging. If it is lateral, whether it is trapezius or rhomboids. Test the key muscle. Only 3 muscles to be tested key: the serratus anterior, the trapezius, and the rhomboids, and that will give you the clinch the diagnosis. Majority improves by non-surgical treatment. If they are not improving by non-surgical treatment, the one thing test that will help you to decide the surgery is the scapular compression test. Now that will tell you whether she will be needing benefiting from the surgery or not. I think with that, I thank all you for the patient hearing. Thank you very much.
Thank you, Dr. Sibin. It was an excellent presentation, very informative, and there were so many things which at least I had not known. And of course, it's not as uncommon as a Sprengel shoulder. We do see some cases quite often. We are running pretty slow. We have 2 more presentations. So any comments from the faculty first?
Can I ask a question, Dr.
Yes,
Gupta?
yes, please.
Yeah, excellent lecture, Dr. Sibin. I really enjoyed what you told. Can you throw some light on the sick scapular syndrome? Sick scapular syndrome?
So the sick scapular syndrome, is basically another terminology for scapular dyskinesia. It's an acronym that stands for scapular malpositioning. S for scapular malpositioning, I for inferior angle prominence, C for coracoid pain because of the overaction of the pec minor, and K is for dyskinesis. Okay, so it's basically you are discovering abnormal scapular motion. So it's a scapular, refers scapular dyskinesia is a broad terminology that means there is an abnormal movement even at resting or during movement or active movement of the shoulder. So it's a terminology that describes scapular dyskinesia. It's not, it covers the scapular winging comes under that, it's a part of it, but both are not same. So it's a basically acronym that stands for.
What is the treatment for this type of thing? What is the treatment usually for sick?
Sick scapular syndrome, basically treatment is strengthening of the periscapular muscles and core strengthening. Basically physiotherapy. Oriented physiotherapy.
Yeah. Thank you.
Thank you. Anybody else? Upesh, anything you want?
One comment only.
Yes.
One comment only that
yes,
usually this type of cases, winging of the scapula, is not given as in examination, but theoretical point of view in new normal situation or new normal examination system. This is very, very important, and the information that has been given by Sabin is excellent. And I request all PGTs that should be remembered, because in new normal situation, a scapula will be shown, winging of the scapula, and some theoretical things will be asked. So this is very important for the PGTs as well.
Sir, we will have all the lectures on the YouTube, so anybody can, any postgraduate can refer anytime. Sir.
So this is highly informative, and this is important for the PGTs.
Thank you, sir.
Thank you, sir. Thank you, Dr. Ray. Karthik, Bhupesh, anything you want to add?
Fantastic lecture, Sibin.
Thank you.
Just pointing what Sibin put in the list, scapulothoracic bursitis and osteochondroma of the anterior wall of scapula is not very uncommon. I think we have all seen that. So doing a scapular wide view X-ray is a very investigation and very important to pick up these things. So I think that for postgraduates, they also should not think it is a very uncommon thing that we are not seeing. In fact, scapulothoracic bursitis is a very common presentation. Maybe not an exam case, but once they go, they're going to see that on OP basis regularly.
Very true, very true. Anybody else? At a Pasardi, anything? Yes?
Excellent discussion and a very informative discussion. Thank you, Sabine.
Thank you,
one thing he has rightly mentioned in etiology, that is the long thoracic nerve palsy, or the most common etiology of the wing scapula is usually due to the damage or the impaired innervation of the serratus anterior muscle. But we should keep in mind that less commonly the scapula can wing laterally due to the damage of the trapezius and lumbotus muscles also. And only these three muscles, if we keep it in mind, then they will go through all the examination as well as test and as well as the concept management of the of this winging of scapula. So I will emphasis, rightly mentioned by Sibin, just I have to emphasis on this point so that it is made easier for the postgraduate student to examine the patient. Thank you.
Thank you, Rapasadi. Shah?
Yeah, Dr. Shimin. Very good lecture here. Very confident. I hope there were no lies in between. I couldn't follow you so fast. You were very clear and good. It was excellent. Yeah, I had a lot of learning in this. A lot of plastic surgeons also operate in this area producing complications. Can you mention a few? They take so much of graft from the chest wall and all the muscles and along with the nerves and vessels.
Yeah, so any surgery around the chest wall, as you told, and because the nerve has a long route, any surgery along the chest wall, like the pre-fascia graft, can lead to the long thoracic nerve palsy. So any thoracic surgery can lead to it. And we commonly, patient commonly doesn't, because they are operated for a bigger problem, they don't look into the shoulder pain. Usually this is usually missed. And they came for the diagnosis usually made late. The scapular winging is a very common problem among the people. If you look at your patients, even a routine patient, the secondary scapular winging is so common. And if you treat that, the majority of the majority patient will be very happy. And we usually treat the other problems, the subacromial or the shoulder problems, rather than focusing on the base. The scapula is the base on which the shoulder, the humerus is acting. So unless the base is solid, the humerus cannot act properly.
Yeah.
Thank you, Dr. Sibin. Is there any other questions? Anybody else? Go, Dr. Gopi, anything? Okay, then we'll go to the next talk. We have one more talk after Gopi's talk. Dr. Gopinath will be talking on shoulder instability. Yes, Gopi, we can see the slide.
Just put it on the play mode.
Okay, Gopi.
I take this opportunity to thank IOA and Professor Rajgopal for inviting me to present this topic in front of the subject. Sorry, the topic is changed, so I'll just shift to the original topic.
Fine. Whichever you are comfortable with, Gopi. Meanwhile, Dr. Sangeet, while Gopi is loading, Sangeet, any one thing you want to say about winging of the scapula? It's not a very commonly kept case in the exam, but it's commonly seen. Sangeet? Sangeet? Sangeet Gawale?
Not there, Ravi.
Yeah, I am there.
Yeah.
See, apart from a short theory question, probably at our times, we have seen them as short cases coming in the exam, but nowadays they are not seen at all being kept for their exams.
Very true. But Sibin, what are the common causes in our days? Maybe Gopakumar or it was polio. We used to get a lot of polio patients with Wingy.
Yeah, polio I have mentioned, but we don't see nowadays, sir.
Yeah, nowadays we don't see.
It's listed in my talk, but I didn't mention because
Yeah,
it's not seen nowadays.
Yes, Gopi, please carry on.
Once again, thank you, Dr. Rajagopal and IOA for giving this opportunity to present this topic. So this is a joint, as we all know, as we see maximum instability and mobility at the expense of stability. That's a feature of shoulder joint, and is most frequently dislocated. And more than 50% of all dislocations are in the shoulder joint. Now, when a case is kept in the examination, history is very important, and also a few points in the history I will mention: the age of the patient, whether it is traumatic or atraumatic, whether it is associated with pain. That's a very important feature. So if there is an instability which is not painful, then the management is going to be different. And if the subluxation or dislocation is painful, the management is different. So I'll come to that in the next slide. So the history of pain and type of pain and how the injury occurred, and whether it's a voluntary dislocation, all these things are very important in the history. And the most important point in the history is whether the patient has got a convulsive disorder, because the post-op management and the management of the patient is going to depend on history. Before going to physical examination, I will just mention a few of the anatomical features which will help us to understand the special test as well as the important points in the physical examination. So as I told, stability is the least one, or it's the most unstable joint in the body, but the mobility is maximum. So mobility is achieved at the expense of stability. But instability is not equal to joint laxity. But laxity means incomplete loss of glenohumeral articulation. It's unassociated with pain. That's laxity. And it could be a subluxation or a dislocation. And a few anatomical features I will just brush through before going to physical examination. The most important features which keep the joint in position or intact are the bony anatomy, the negative pressure within the joint, and of course the most important ones are the dynamic structures. So what are the static structures? The glenohumeral stability is maintained mainly by the static and the dynamic structures. The static structures are the glenohumeral ligament, the labrum, the articular concavity, intra-articular negative pressure, and the dynamic restraints are the rotator cuff, the rotator interval, the biceps, and periscapular muscle. So the most important anatomical feature is that it's a concave glenoid, which is given more depth by the labrum and the glenohumeral ligament. And the most important one is the inferior glenohumeral ligament, even though we have a superior, middle, and inferior. And the inferior glenohumeral just acts as a hammer along with the capsule. So this is the most important static structure for the stability. And if you have a disruption of the IGHL or the inferior glenohumeral ligament, first you get an inferior subluxation, then it goes anteriorly. So that's the mechanism of anterior instability. So there are so many other osteology points which will be very important for the postgraduate to understand why a joint is going to be stable. It's a pear-shaped glenoid, and in that glenoid, a globular humeral head is articulated, and it is around 7 degrees of retroversion and 5 degrees of the superior tilt. And this version on the humeral side and the glenoid is very important. And we all know that the humeral head is bigger than the glenoid, and that is why you get a lot of movements like circumduction. But it is pear-shaped. It is narrow superiorly and wide anteriorly. So if you have a huge head articulated with a small glenoid, of course mobility you will get, but at the expense of stability. So this is one point you should understand. So it can be easily assessed in investigations like MRI. And this is one point you should remember. It's a negative intra-articular pressure, which will give a lot of stability. And for this, integrity of the anatomical structures is also important. When one of the anatomical structures like a labrum is avulsed, you don't get a negative intra-articular pressure, and that causes instability. So when you repair the labrum, it is not that a piece of labrum you repair is retained and that will give stability, but it is the negative pressure which will develop when you repair the labrum, and that's important for stabilizing the shoulder. So the dynamic structures are the cuff muscle. Now, when you have a massive cuff tear, that's one cause of instability. Now, why cuff tear causes instability? Because as I told, it's a pear-shaped glenoid articulated with a huge globular humeral head. And if the deltoid has to act, the humeral head has to be stabilized within the glenoid, then only the other abductors can act. So if the rotator cuff muscles are not acting, then of course there is going to be a reverse scapular rhythm and it's not going to be a normal scapular rhythm. So if the cuff muscles are not there, the glenoid cannot be stabilized. So within the humeral head cannot be stabilized within the glenoid, and you get instability. So massive cuff tear is one reason why you should get instability. And the important point is that the cuff helps in bringing down the huge humeral head into the widest part of the glenoid, and in that position it is stabilized. And when that humeral head is stabilized in that position, the deltoid will act and produce movement. So if such a sort of stabilization does not occur in the shoulder joint, then you get a lot of problems like instability, reverse scapular rhythm, reduced abduction. And that's why in a rotator cuff, even though the deltoid is intact, you will not get abduction. So what you get is the huge part of the humeral head will articulate with the narrowest part of the pear-shaped glenoid, and that will prevent further abduction. So even though the deltoid is normal, the deltoid will not be able to act because the humeral head is not stabilized. First of all, it is not brought down to the widest part of the glenoid, so it will not act. So as we taught the postgraduate students that the initial few degrees of abduction is created by the supraspinatus of the cuff has already changed. The concept around the shoulder has changed, and we now know that it is not the initial 5 degrees of abduction or 10 degrees of abduction that is created by the supraspinatus. It is actually the cuff muscle which brings down the globular humeral head to the widest part of the glenoid and stabilizes it there. So from first few degrees itself, the deltoid can act, and this principle is applied in the reverse shoulder arthroplasty. So rotator interval is also important. The long set of biceps, another stabilizing structure, and also the periscapular muscles, which is already discussed. I am not going into the details. Now, what is the pathological anatomy? As you all know, there could be an abnormality in the normal anatomy that will produce a subluxation or dislocation or instability. The Bunkard's lesion, as you all know, is an avulsion. It is an avulsion of the glenoid. It could be an avulsion of the glenoid labrum along with a piece of bone, which is known as osseous Bunkard's lesion. If it is posterior, you call it reverse Bunkard's lesion. And if you have an avulsion which is small, you call persis. If you have an anterior periosseal sleeve avulsion, you call it arthroplasty lesion. And there could be a cartilage piece also which could get avulsed. So these are some of the pathological features by which you can get a dislocation. Another point is another pathological feature is a posterolateral defect in the humeral head, which is already discussed by Dr. Bhupesh. And this is again a reason why you can get a dislocation. So this is a Hill-Sachs lesion. So I'm not going to the details. It is already discussed. Now, another point you should remember is excessive laxity. You have to do a good examination of the patient, general examination, to assess the laxity of the other joints. Excessive capsular laxity could cause a multidirectional instability. And traumatic instability is again a fracture or an avulsion of the glenoid. And the mechanism of injury is an axial load in a flux adducted position, and it results in a avulsion of the labrum or a piece of bone or a fracture of the anterior brim of the glenoid. So this concept is that when you have a problem with the restraints, you have two restraints, the primary restraint and the secondary restraint. The primary restraints are in the direction of instability, and the opposite one is the secondary restraint. So you have to examine both anterior and posterior. So basically it is classified into traumatic and atraumatic. Traumatic is less laxity, it is unidirectional. Atraumatic is more laxity and multidirectional. This is a famous classification which is known as a traumatic unidirectional Bunkard's lesion, and surgery is a treatment. This will be asked in the examination. And the other is atraumatic, multidirectional, bilateral, rehabilitation is the treatment, and inferior capsular shift or closure of the rotator interval could help the patient. So the chronic instability is again TUPS and embry. I'll just repeat it. TUPS is traumatic unidirectional Burkhardt lesion and surgery is a treatment. Embry means a traumatic multidirectional bilateral rehabilitation, and inferior capsular shift with a closure of the rotator interval is going to be the treatment. This is the oldest classification. Yeah, so many other classifications have come up, like a Stanmore classification. I don't think it is very important for the PG, so I'll just skip that slide. Now, the frequency is very important. When you look at this patient and examine this patient, acute or recurrent or a fixed dislocation or subluxation, and the etiology, is it traumatic? Is it atraumatic? It is a neurological problem or epilepsy. This is also very important. And when you look at this patient, you have to look at whether it's an anterior instability, whether it's a posterior instability, inferior instability, superior or multidirectional. And the degree of instability is also quite important, the subluxation or the dislocation. Now, for the patient, it's very important to tell you everything, and for the surgeon, it is very important to take a detailed history on how the injury has occurred. This I have already discussed in the beginning of this presentation. Now we'll move on to the physical examination. As I told, this is going to be a case in your examination. This is it's not very uncommon to get a case like a dislocated shoulder or an instability in the examination. So you have to follow all the steps like inspection, palpation, range of motion, movement, measurements, the winging, then the neurovascular testing, general ligamentous laxity, and special tests. And special tests are very important in your examination. So assessment by the surgeon is a frank instability or it's just an apprehension which is positive, and you have to understand that you have to follow the sequence of examination like inspection, palpation, movement, measurement, special tests like that. So an inspection is usually atrophy or asymmetry around the shoulder. Tenderness is very important to be elicited. If a joint which is unstable or dislocated or subluxated is non-tender, then it's going to be a ligamentous laxity, which is cause instability, and the treatment is going to be different. If there is some pain, it could be traumatic, and the treatment is going to be different. So it's very important to elicit tenderness. Then active and range of motion and the passive range of motion, and strength of the muscles like a deltoid, rotator cuff, and the scapular stabilizers, the muscles which attaches scapula to the thorax, and the muscles which attaches the scapula to the humerus. So you have to classify those muscles and look for the power and strength of the muscle. Assessment of the nerve injury and impingement and special tests. I'll go in detail in the next slide. So anterior dislocation of the shoulder. This is one unreduced dislocation. This is not part of this topic because instability is given, but an unreduced anterior dislocation also you can get in the examination. And the simple tests are Hamilton's ruler test. I think everyone will know about what is this test means. To put a scale on the lateral aspect of the humerus, usually the lateral epicondyle and the humeral head, when the scale touches, it will never touch the acromion. If there is a dislocation, the scale will touch both the tip of acromion and lateral epicondyle. So it's a Hamilton ruler test. Another test is Duga's test. Ask the patient to lift the affected limb and keep it on the opposite shoulder. If the patient cannot do that, then that means the shoulder is dislocated. And Calave's test is a test where you measure the width of the axillary fold. In Calave's test, if the width is more than the opposite side, then the shoulder is dislocated. Now we'll go to the provocative test and quantitative test for instability. So tests for anterior instability are the crank test, the fulcrum test, job test, and the test for posterior instability. Now, this is a sulcus test. It's a very famous test. Patient is sitting or standing and the shoulder is in neutral position, the muscles are relaxed. You just give a downward pressure. The dimpling of the skin below the acromion or widening of the subacromial space more than 2 centimeters means that the joint is unstable. So this is sulcus test. Then there's a shift and load test. It's a sign of instability. You can subluxate and relocate. And this is a test for instability. Now, what is anterior instability? The provocative tests are the crank test. Patient sitting and the arm abducted 90 degrees with the increasing axial rotation. The examiner exerts anterior translatory force with his thumb placed posteriorly on the humerus and watches for apprehension. So it's the apprehension test. Apprehension test is diagnostic of instability. And if only pain, if there is pain, then it's significant. If it is painless, then it's also significant because we look for laxity. Another test is a relocation test. Examiner repeats apprehension test and notes the amount of external rotation before the onset of apprehension, then applies posterior stress on the humeral head and repeats external rotation whenever, and again note that external rotation at the onset of apprehension. Increase in external rotation is going to be a positive test, and that is the relocation test. So this is the relocation test. Now the fulcrum test, the patient is supine, the scapula supported at the edge of the table, and the arm is positioned at 90 degrees of abduction with increasing external rotation, and the examiner watches for apprehension. Now there are some provocative tests. This is a jerk test. Patient is supine with 90 degree forward flexion, shoulder and elbow at 90 degree, and examiner applies posterior directed force holding the forearm. So the jerk test is also diagnostic of an instability. And the circumvention test is the patient standing, examiner standing behind and holds the arm in extension and abduction, performs circumvention. Visible subluxation, apprehension in a position of forward flexion of 90 degree and adduction is a sign of instability. So these are the special tests for a unidirectional instability. Now, multidirectional instability means there's going to be a ligamentous laxity, and you get some patients who voluntarily dislocate. You can subluxate or dislocate the shoulder in any direction. So it could be a psychiatric or a psychosomatic problem, or it's a ligamentous laxity you have to define. Now, when you get such patients, you have to investigate. You can ask for an AP view. You can ask for a normal AP view and look for the relations of the bony structures. You can ask for an axillary view, or this view will tell you what is the relation between the humeral head and the glenoid in actually anterior posterior direction. So whether it's a posterior dislocation or not, if you have any doubt, always ask for an axial view, and that will tell you whether there is a posterior dislocation or not. Otherwise, you will miss a posterior dislocation. So right shoulder in internal rotation and scapular Y view, this already highlighted. When you have a patient with a suspected problem under the scapula, this X-ray will help you. So these are some of the views which will definitely help you to identify instability. But if you take a CT scan, all these X-rays, even though they are helpful, you get more information in a CT scan. You know about the bone loss, bone loss on the humeral head and also on the glenoid. And MRI is also important. So in many of the shoulder instability cases, you need both MRI and also CT scan, because MRI will tell you about the soft tissues like labrum and cuff muscles, and it will not quantitatively tell you what is the bone loss, which has to be assessed in a CT scan. So you need both CT and MRI to assess this patient to decide about the final management. So MRI is also important about soft tissues. Bone is well seen in the CT scan. So if somebody asks you the examination which investigation you will do, for the bone it is CT scan, for soft tissues it is MRI. Now we'll go to the treatment part. I just brushed through that. You not get a detailed discussion in the examination about treatment, but still you should know some of the features. So it's very important to know in a nutshell what will you do for such instability cases. So it is a young patient or a high activity level, and procedure of choice is arthroscopic bulbar lesion with capsular plication, open bulbar lesion with capsular sheath, open capsular sheath or remplissage. That is a soft tissue procedure which you have. Then bony procedures are the Bristow's procedure and Letarge's procedure. And it's almost the same procedure, but some little difference, because two screws are used and how you put the graft is important. Now the treatment, bony treatment, we all use this Letarge technique. Then you have a owl technique, which is not done nowadays, but you should know for the reasons of history purpose, or if you're not you're interested in the history, that's a putty flat, and then Magnusson's procedure is not nowadays done. So capsular plication, and we need a definite reason why and how much you should shift the capsule. And if you shift too much, it is going to have stiffness. So capsular shift is one procedure which you do especially in traumatic cases and laxity, and sometimes you close the rotator interval as well to produce some sort of a stability. So you have to define group. You have to assess the patient, the anatomical features, and then you need a well-motivated patient who is able to participate in the rehabilitative process. Then all this surgery is going to be useful. So you can use a capsular plication for traumatic cases, and this is one technique used for laxity cases. So scapular labral repair, like a Burghardt repair or a modified repair, or a subscapular procedure like Puticlat, which is for historical reasons you should know, and arthroscopic Burghardt repair is a gold standard. And open Burghardt lesion, it's going to be a difficult procedure for surgeons because it's very difficult to reach that area. But there are of course some surgeons who think that open Burghardt lesion repair also has got its own goal. But the gold standard nowadays is arthroscopic Burghardt repair. And because it's very difficult to reach that area by open means, for the scopic surgeon it is so easy to reach that area. So you need to know about Puticlat. This is not very important for your examination, but somebody asks, you should know what is the Puticlat procedure. It's a double bracketing of the subscapularis muscle. Nowadays it is not done, but Letarge procedure is still used, open or arthroscopic, and it's where you cut a piece of the coracoid fossa with the short of the biceps and you fix it to the scapular neck with two screws. So Letarge procedure and the indications all depend on how much bone loss you have. This is already highlighted by Dr. Bhupesh Karthik, where he told that 25% loss is one benchmark. You decide whether you need a Letarge procedure or not. So when there is a defect in the anterior glenoid, you have to reconstruct it. You can use a iliac crest bone graft, or you can use a coracoid process along with short of the biceps. But the advantage of using a Letarge procedure is that you have a sling effect of the short of the biceps anteriorly. But if you use a iliac crest graft, that sling effect is not there. So better procedure is a Letarge procedure. So it's a Letarge procedure. This is in nutshell about the management of these cases, and I'll just go to two slides on posterior instability. Here, if you take an X-ray, you see what is known as a light bulb sign, and this you think that the head is within the glenoid, but if you take an axillary view, you'll know that the head is outside. So that's the importance of taking an axillary view in the shoulder instability or dislocation case. Now, posterior procedures. Here you have a reverse Burghardt lesion and reverse Wilczek lesion, because the posterior labrum has doubled. So you need an arthroscopy for open repair. Again, arthroscopy is easier for a posterior Burghardt lesion repair, and that is about posterior instability as well. Now, the patient has to follow regular phases of rehabilitation. If that is not followed, then the outcome of these patients are going to be very bad. So rehab procedures, you have to optimize on core muscles, the scapular muscles, range of motion, and the patient has to involve into the best rehabilitation procedure as possible if the patient or the surgeon wants to get the best result. Thank you for patient listening. Once again, thanks to IOA and Professor Rajagopal for giving me this opportunity. Thank you.
Thank you, Dr. Gopi, for giving a very brief summary of all the things and covered everything. As of the lot, it's definitely one of the most common exam cases and seen. We have one more talk and it's getting late. Any additions from the faculty before I go to the panelists? Bhupesh?
Very nicely presented everything, sir. So after Professor Gopinath's talk, nothing more to add.
Fine. Okay. Dr. Sangeet?
He has covered everything. I think there is nothing left now.
Thank you. Dr. Celio?
One question I have, Gopinath. Do you do both CT scan as well as MRI in all your patients of recurrent dislocation before surgery?
What we do is we do limited cuts in CT and MRI. We need to both. In short, we do both, but it's not a detailed CT cut. CT limited cut plus MRI. That's what radiologists do because it's safe for them also.
Thank you. Dr. Chinmay? Sir, anything? Any comment?
Nicely discussed. Nicely discussed. Actually, PGT mostly faces the anterior dislocation, the current anterior dislocation. So that part is nicely covered and it will be very much helpful to them. Thank you.
Thank you, sir. Dr. Patsardi? Dr. Patsardi?
Yeah, it was an excellent talk by Gopinath. There is nothing more to add. Thank you, Gopinath, for your excellent talk.
Thank you, sir. Any other faculty? Any of the Dr. Harshad or Dr. Ray?
It's excellent.
Okay. Thank you,
No
Gopi.
doubt about it. He's covered a large subject in a small time.
Gopi is a large, big man looking small.
Yes,
So like that. Thank you, Dr. Gopi. Can I have the Dr. Gawade? First of all, I apologize for making you wait so much time. Really went a little more than what I expected. Please pardon me. Can we have your talk?
So that is an indication to finish fast, right?
Please share your screen, Dr.
Yeah. So am I visible and audible?
Yeah, we can see you.
So my talk is on locked posterior dislocation of a shoulder, and I work in Mumbai in these hospitals. So coming to the case, he is 30 years old, had a fall 4 months back, and as expected in interior of India, he was treated by quack, and the X-ray was taken, and as usual, it was missed. So initial misdiagnosis is very common, and because in a posterior dislocation, the X-ray you take looks normal to some of the busy surgeons. And if you don't focus on it, and the points which I will cover in the next slides, it is often misdiagnosed as frozen shoulder or usually a post-traumatic stiffness. So in the history, what is important is anterior dislocation and the posterior dislocation. The anterior dislocation has been covered earlier. It is more common as compared to the posterior dislocation. And this posterior dislocation usually is seen those who have seizure disorders, those who have an electric shock, and those who fall on an outstretched hand. So this patient had a fall on outstretched hand. He didn't have seizure or an electric shock. And the important clinical examination, the points here, at 4 months, he did not have any pain, but he had restriction of movements. His shoulder was almost stiff and the arm was locked in an internal rotation of 40 degrees, and it was obviously adducted. So no further active or passive external rotation was possible from this position. And as happens in dislocation, usually the subacromial space is empty. The normal globular appearing shoulder is not visible, and at 4 months there is some deltoid atrophy. So these are the clinical examination which you must look for, and some of them were present in this case. Now, why does this happen? What is the cause? It is an involuntary muscle contraction. The strong internal rotators, the lats dorsi, the pec major, the subscapularis, and the teres major, they simply overpower the weak external rotators. That is the infraspinatus and the teres minor. So it's a muscular cause basically which is responsible for the dislocation. And what is important for diagnosis is AP view. Most often we don't get a proper AP view, and axillary view again is missed or it is not taken most of the time. On the right hand side, you see a clear picture where you can see a normal appearing X-ray, and you can see the glenoid very well, the humeral head which is globular, and the glenohumeral space in between. If you take a normal X-ray view as discussed earlier, as shown in the pictures, then ideally you should get this type of view. Out here in this our case, what you see is the glenoid is vacant. That means the globular humeral head, probably the shape has changed and it is not articulating with the glenoid cavity. So often that can be confirmed once you take an axillary view. So what you see here is, if you follow my cursor, this is the glenoid cavity, and this is the anterior part of the humeral head, and the posterior part of the humeral head is locked against the posterior rim of the glenoid. So this is a radiological diagnosis is of a locked posterior dislocation. Now, why it is often missed? Because when we don't take a normal standard view. So this is the another patient's X-ray who had a posterior dislocation, not this present X-ray, not this present case which we are discussing, only to bring out some of the radiological signs which will be important when you see or notice this X-ray. The picture on the right is of an anterior dislocation where you see a empty glenoid. So in an anterior dislocation, the humeral head will be under the coracoid process and the glenoid will be entirely empty, like you see in a normal X-ray. And here what you see is, you can see the shape of the humeral head which is changed. And there are two important signs. These are the crescent sign and the pear shape. This is not classical pear shape of the humerus, but in a dislocated posterior dislocation, the humeral head appears to be pear shape. Then the second important sign is a crescent sign. So if you notice here, the overlap of the humeral head and the glenoid cavity or the glenoid, there is an overlap of so much 6 to 7 millimeters. So that is a crescent shape or a crescent sign which is seen in posterior dislocation, which is normal view, you don't see that overlap. Apart from that, if you follow, like the normal head appears to be globular and very clear. Out here, if you follow, there is an impaction. If you draw a line and follow that, there is an impaction of the humeral head. Whether it is anterior or a posterior, we don't know. So if you view the AP X-ray properly, you will be able to make out these signs, and it will be very less often you will be missing these posterior dislocation in the X-rays. So coming back to our case, this was the X-ray where you see a vacant glenoid sign. So these are 3 or 4 signs: the pear-shaped humerus, the crescent sign, the vacant glenoid, and the trough line. So these are the 4 or 5 signs which you follow. You will never miss a posterior dislocation. Any further investigation is required? Yes, a CT scan is required because that will decide what kind of surgery you will be following. Both 2D CT and 3D CT is important. Normally, the important structure what you are supposed to see is the bicipital groove. On the medial side is your lesser tuberosity. On the outer side is the greater tuberosity. And the humeral plane, like it makes that will be visible when you do a 3D subtraction of the glenoid. So this is a normal 2D CT where you see there is nothing much we can make out in a coronal. But if you see the axial view, it is very important. The normal view, you follow the bicipital groove, as you can see here. On the medial side is your lesser tuberosity, on the lateral side is a greater tuberosity. So in our case, if you follow, so this is a bicipital groove. On the medial side, this is the anterior side, this is the posterior side. On the medial side is a glenoid tuberosity, is a lesser tuberosity, and the greater tuberosity is intact. And what you see here is a fragment which is posterior, part of the humeral head. Now, ideally, that is should be here like this, so that the head appears globular. So there is some impaction of the anteromedial side of the humeral head, and that is the reverse Hill-Sachs lesion. In an anterior dislocation, you will see the same Hill-Sachs lesion on the lateral side in a chronic anterior dislocation. So here, this is called as a reverse Hill-Sachs because it is on the opposite side of a normal appearing Hill-Sachs lesion. Apart from that, on the greater tuberosity, what is attached are the rotator cuff, the supraspinatus and the infraspinatus, and on the medial side is your subscapularis. So the bicipital groove has separation of subscapularis on the medial side and the supraspinatus on the lateral side. These are 2 important structures and the landmark when you are doing a dissection for your surgical procedure. The 3D CT in which you subtract the glenoid. As the glenoid is intact, you subtract the glenoid, and then you can have the appearance of the humeral head. So what you see here is the anterior part of the glenoid, or the anterior part of the humeral head, which is separated, and even the distance between the shaft and the humeral head has increased, suggesting probably there is also a fracture of the neck. So since this is a 4 months, you cannot make out. Apart from that, what you have to see is what is the relation of the glenoid. Now, if you can see this view, the glenoid and the humeral head. Most of the humeral head is posterior, and some part of the humeral head is articulating. So if you see the similar view, ideally, this is the glenoid. So the glenoid should be in the center of the humeral head. Half of the posterior half would be seen like behind, and anterior half of the humeral head will be seen anteriorly in a normal view. So here in this case, you see most of the humeral head behind. And that is exactly when you reconstruct, you will be seen. This is the part of the anterior part of the humeral head which is articulating with the glenoid, and the major part, probably it is fractured, is articulating with the or it is dislocated posteriorly and it is locked. So what was done in this, since it was 4 months old, a surgical procedure wherein we take an approach of a deltopectoral approach right from the coronoid process up to the insertion of the deltoid. We take an incision, we release the lesser tuberosity partially and osteotomize it, so that then you can open the joint, release the scar tissue between the humeral head and the posterior glenoid rim. The humeral head, which is locked, it is unlocked posteriorly by pushing it and laterally subluxating it and then externally rotating it. So normally what is important is there is an average retroversion of about 19 degrees of the humeral head in relation to the medial epicondyle. And in this particular case, that probably the head was fractured, and hence the major part of the head was retroverted. I'll come to the clinical pictures. So what was done was planning an osteotomy through the fracture site, the old fracture site, by marking with the K wire. So after doing the osteotomy, you can see this is the lateral epicondyle. The medial epicondyle is on the inner side, and you can see how much is the head retroverted. So osteotomy was done here to correct the retroversion of the head through the original plane of the fracture line after identifying with the help of a K wire. So this is how the osteotomy was performed. And once the osteotomy was opened, then this is the anterior part of the humeral head. Then the posterior part of the humeral head was relocated over the glenoid and then fixed with temporarily K wires. And then this is how it was reconstructed with the help of sutures and a plate. And the defect was the Hill-Sachs lesion, or the defect on the anteromedial part of the humeral head, was covered with the bone graft and the transfer of the subscapularis. I'll come to it again. So this is the final C-arm picture. This is how the head was reconstructed. And then the lesser tuberosity, which is here, so it was transferred in the defect. So the red mark area is the original site of the lesser tuberosity. So it was transferred little bit medially and then fixed with the screw. So this screw represents the fixation of that, and some graft were used to fill up the defect. So this is a McLaughlin transfer of the subscapularis. For a defect, usually when we have a defect of 20 to 40%, this procedure was done. This is the 6 months post-op healing of this patient, and that is his range of movement at about 9 months. So he can do the complete circumduction, that is the external rotation, and the internal rotation the patient has. At 18 months, he doesn't have an avian, but this screw which was fixing the lesser tuberosity has little bit migrated, and that is what is bothering him. So subsequently, we would be removing that. So to the treatment of posterior dislocation depends on the size of the defect, the duration of the dislocation, age and activity of the patient. Is there any role of conservative treatment? Yes. In elderly patient who have very low demands, they can undergo a supervised neglect. Those patients who have uncontrolled fits, they can be left alone and they can follow the same neglect. and those who cannot participate in the rehab program, those who are not mentally fit, those who cannot take part in the physiotherapy, they can also be conserved. Surgical treatment is basically based on non-anatomic and anatomic reconstruction of the reverse Hill-Sachs lesion and or shoulder arthroplasty. Close reduction, when do you call it chronic? When it crosses a duration of 3 weeks, usually they are unreducible. So any posterior dislocation which is beyond 3 weeks is called as a chronic, and that should be considered for a surgical treatment. And second dictum is you should consider close reduction only when the defects, the reverse Hill-Sachs defect is less than 25%. And how do you do the close reduction? Under general anesthesia and muscle relaxant, gentle reduction is attempted by flexing and adducting the arm with the axial traction. Direct posterior pressure on the humeral head from behind can facilitate the reduction. Now, in a situation where there is the dislocation is locked, you have to unlock it. How do you unlock it? Gentle internal rotation may help to stretch out the posterior capsule and the rotator cuff. What is locked, you have to take it laterally by giving a lateral traction. So unless that locked part comes in contact with the glenoid cavity, don't externally rotate, otherwise it will fracture. So lateral traction and then external rotation will take care of unlocking, and then immobilize the arm by the side in external rotation of 20 degrees for about 6 weeks. Sorry. So the locked posterior dislocation, the Hill-Sachs lesion can be divided and classified by a CT scan, and the size of defect, as I said earlier, decides what type of treatment, surgical treatment they will need. If you take an axial scan and divide the humeral head in these two zones, then the one which is articulating with the glenoid, if you have a defect which is less than 25% of the articular surface of the head, that is one case. Second is a medium-sized defect which are between 25 to 50%, like here, which have a CT picture like this, which involve the complete equator or the zone, or the one which you have a large defect of more than 50%. These three categories of posterior dislocation have different management altogether. So our case was like this. It was somewhere a large defect which was more than 50%. So what we had done is a rotational osteotomy, part of the humeral head. So in management, defects which are less than 25%, all what they need is a McLaughlin transfer, where you release the subscapularis from the lesser tuberosity and fill the defect with the tendon. So that will take care of the small Hill-Sachs lesion, and open reduction is all what is required. So defects which are little larger, say 25 to 50%, what you require is a modification of the McLaughlins, wherein you take the entire lesser tuberosity and transfer it in the defect and fix it with the screw. Or you have a defect which are about 50%, they require a rotational osteotomy, and or you fill up the defect with a hollow or autograft and reconstruct that defect. And lastly, those defects which are more than 50% and in elderly patient, hemi or total replacement would be the treatment of choice, as discussed by Dr. Kotwal also. So posterior dislocations, these are very rare injuries. They account to about 1% to 5% of the shoulder dislocation. And one article which you must read and you must follow before, if you're doing a surgery, this is a very important article by Sikak in 2004 that gives you everything what is required. for considering a conservative treatment or a surgical treatment, and if you have to do a surgical treatment, what would be your ideal choice? So this was about a locked posterior dislocation, how to diagnose, what are the radiological signs, which cases to conserve, and if you are operating, what are the different procedure and what we have done in our case and the follow-up of that. Thank you very much.
Thank you, Dr. Sangeet. It was a very interesting case, very well managed, and excellent result. Very well done. And I think that's very interesting also. Thanks a lot. Anybody want to share a similar experience? Not a very common problem.
Yeah, I would like to share experience. We also managed to do a similar case of a locked posterior dislocation where the defect was less than 25%, as you said, case one scenario. And we had to do the mag logging transfer only, and it came. Now, my question to Sangeet is, have you done such cases for unreduced anterior dislocation of the shoulder? And what is your experience in this? Unreduced anterior dislocation, have you done any? Because I just attempted one and I found it very difficult to position it back, and I had to almost transfix the thing, for stability. So what is your experience in unreduced anterior dislocation, say 3 months old?
It's a nightmare. It is a nightmare if you have that late anterior dislocation. And the struggle is exactly the same, where you have to go underneath the conjoint tendon and you are scared of the brachial plexus and the axillary artery. So only what is required is a dissection. But usually in anterior dislocation, we don't see such large Hill-Sachs lesions.
Correct.
So all what they require is a careful anterior reduction.
But what about the stability after reduction? After reduction, the joint is very, very unstable.
So the 3 or 4 which I have done most of the time, in all of them, I was able to get a stable reduction after refixing. Yeah, reducing it.
Okay. Okay.
Anybody else? Chinmay or Ray?
Yes.
Can I ask?
Yeah.
Chinmay, please.
Yeah. Actually, I managed one posterior dislocation. One of my friend, doctor, posterior dislocation that was managed only by capsular plication. Nothing else had to be done. And regarding the old anterior dislocation, because I work in a rural medical college where lots of cases we get, and it is difficult but not impossible. And after reduction, we stabilize with transarticular KOI for 3 weeks, and then we mobilize. Usually, instability is not a problem. We get not much movement, but it is relatively stable and reasonable functional movement is achieved.
Sir, can I just add, sir?
Yeah, Bhupesh.
Fantastic talk, Dr. Sangeet. Coming to the question asked by Azilio, sir. Sir, anterior shoulder locked dislocations are more difficult to treat surgically, as you said, but are less forgiving. But posterior ones, because their hands are in internal rotation, their ability to do their day-to-day activity becomes very, very difficult. And hence, most of the patients with locked posterior come for help to the surgeon. Many people who are with neglected anterior shoulder dislocations live happily without even coming to the doctor, especially the very elderly. That is what we have seen over in my short experience. But as you said, the instability after reduction might be because of glenoid bone loss in these cases. Anterior glenoid bone loss in locked anterior shoulder dislocation is very common, and trying to address that might solve the problem sometimes to put it back in place, sir.
But
planning before the surgical intervention will help us to identify if there is any glenoid bone loss.
But do you see such defects in anterior dislocation also? I haven't come across the Hill-Sachs large bony defects. It is on the glenoid side, you are saying, not on the humeral side.
Can be, because once it is reduced surgically but not stable, then maybe we are missing anterior glenoid bone loss, is what I'm trying to say. Because when there is anterior glenoid bone loss, the anterior capsule becomes lax in mid-range. So the humeral head tries to fall off anteriorly because there is nothing to hold it anteriorly, especially when the arm is brought into mid-range, because there is nothing to hold the humeral head anteriorly, and the capsule relaxes because your arm is anterior. The capsule also relaxes, there's nothing to hold, then this falls off anteriorly. So that could be the reason for instability after reduction in these cases, which Dr. Zelio asked about.
So can I add? Hello?
Yeah, please. Yeah, Sibin.
Yeah, so I'll agree with Dr. Karthik. Suppose in a chronic anterior distal, if it is unstable after reduction, the only option that's available for us is you do most likely the cause would be a glenoid bone loss. So reconstruct it with a letarge, because that will improve your exposure also. And it will give us stability. There is nothing else that we can do at that same time. So what's your opinion, Dr. Gowale? Can we add the letargy along with that if it is unstable after your open reduction?
Yeah, I said that earlier. It is usually the glenoid defect which has to be reconstructed.
Definitely, yeah, I think.
Right. I think what you are saying makes sense now, because whatever I had done was 15 years back when knowledge of this letargy and all was not so good. So maybe that could be the cause. Yeah, could be the cause. Correct.
Dr. Ray, anything you want to add? Sir, unlock.
I have unmuted.
I have experience with the multi-directional instability. So sometimes it becomes anterior dislocation, posterior dislocation, and I had an observation in voluntary dislocator. Voluntary, they get pleasure. They have got some psychological problem. Voluntarily, they do it. Sometimes, I tried to treat it. I did the surgery, but within few months came back with the same condition, because it has some psychological problem. Voluntary, that is also a part clinical.
I think you should not touch these patients. Voluntary dislocators, you should just leave them alone, sir. Because if you touch them, they're going to come back again to you every now and then. So you just treat them conservatively, I think.
They come. If you don't touch them also, they don't leave you. If you
I know.
touch them also, they won't leave you.
But it's safer as far as all medical legal issues are concerned, keep them alone, because they're not going to be treated.
We cannot be psychiatrists, no? Surgical psychiatrists.
Sir, one question to Dr.
Yes,
Sir, is there a role for a posterior approach along with the anterior in a unreduced posterior dislocation?
It has been described, but we are unfamiliar with it.
Yeah,
As such, posterior dislocation is so rare. Like all the faculties, we had 2 or 3 cases in lifetime.
Okay, sir. I heard in some conference, that's why I asked.
Yeah, it is. But the exposure is too difficult for us.
Okay.
But most of the surgical work can be done, but from the anterior standard golden deltopectoral approach. The gold standard is still a deltopectoral approach. And second, like the McLaughlin or where you have to fill the defect with Otto or McLaughlin procedure, it is much easier to externally rotate and work on the anteromedial side rather than going from the difficult posterior side.
Okay, agree, totally agree. Taken point.
I think I should, first of all, it is 9:33 on September 5th, Teachers' Day. So many of the teachers, all of you have taken your Saturday evening, all the faculty, all the panelists, all the office bearers, PG committee members. So nice of all of you to have, given immense knowledge to the students. It was a very interesting session. Very useful and very informative, not only to postgraduates, but I'm sure to many of us. And the only thing left behind is the questions from students. Quite often, Dr. Manish has a problem. There was electricity failure in that area due to some rain or thunder showers in Delhi. So we have a delay in communication. So if at all is there, we will communicate to you, and we will see how. Whether if you even send the reply to us, we will inform them. We will see how that can be done. With your permission, if there is nothing more, anybody want to, can I conclude or? Okay, with your permission, I want to thank all of you, again, all the faculty, panelists, consultants, office bearers, everybody for taking your time and giving to us, and Dr. Meena, our president, and our Honorary Secretary of Srivastava join me in giving their regards and thanks. Ravi?
Yes, sir. Sir, can I end this?
Yeah, can we go off the line?
Yeah,